Good morning. We are so excited to have you join us here today for the webinar, What You Should Know About Concussions, Professional Perspectives on the Invisible Injury. We are bringing this to you because it's a significant health topic, and we feel it's important to get information out to the public to raise their awareness and understanding. So we have a few things that we need to show you first. We have a disclaimer. The webinar is a forum for education and awareness of concussions. It provides general information about concussions and concussion management. If you suspect that you have a concussion or traumatic brain injury, please seek medical attention and medical advice from a health professional. Okay, so the next thing, we'd like to, first of all, thank you all for joining us this Saturday morning. We have people from all over the world that have joined us, so it might be good evening or good afternoon to you. We so appreciate you taking the time to be with us. We want to take a shout out here to the CSUN Foundation for those of you who gave us some donation for student scholarships. Thank you. Here's another opportunity. We are providing the opportunity to double the impact of your donation through the CSUN Foundation. So a shout out to them. For Matador Hearts, for Matador Minds. You are under no obligation to make the contribution, but know that your impact will be doubled. Now, here we go. There are two things on the bottom of your screen that are available to you to communicate. We want this to be an interactive webinar. So, you know, there's a chat feature, so you can type in your comments. And on the bottom, we also have the Q&A. So we want you to be able to ask questions of our panelists, as well as get answers if at all possible. Some of them will be answered live, and some of them will be answered by the panelists themselves. So let's take a look and see on the chat if you can kind of tell us where you're coming from. Where have you logged in from? Los Angeles, okay, Maryland, San Jose, San Diego, Houston, Sacramento, Orange County, Temple City, okay, Woodland Hills. Wow, look at all these people. Thank you. We love to St. Helena. My goodness. Yay. So Santa Monica, Yuba City, Marina Del Rey, Northridge. Yay, Northridge. Okay, so thank you all for coming today. At least we know the chat feature does work. And please type in your questions as we go along. I'd like to introduce to you our speakers for today, and I'll ask them to come on so you can see their faces. We can forward to the next slide here. I'm Dr. Felicia Conlan. I'll be your moderator, and I'm so pleased and happy. This is a dream come true to see all this happening together. We have Dr. Eric Sletten. Dr. Sletten, if you give a wave there. Dr. Lisa D'Angelo from Sac State. Dr. Nancy Cohick from Cal State LA. Brittany Bingham, all the way from Ohio. She's a certified athletic trainer. Darren Weinstein, who's a performance coach from CSUN, and David Bobrosky, there he is, and Lisa Naugle. So you'll see all these wonderful folks later on today as we proceed through our webinar. We want you to know that we're going to keep this very engaged as much as possible. So we're going to have 20 minutes for each speaker, and then we'll move on to the next person. And so you'll be able to at least get a little bit of information from all of us. We will have, I will be talking about strategies to learn. We'll also listen about a speech language pathologist's role in concussion education, an athletic trainer's perspective. We'll also then take a break around 10:15-ish, and then we'll also talk about the socio-emotional perspectives and sleep disturbances, cognitive rehabilitation, and mild TBI. Take another break around 11, and then return to play the physician's perspective, as well as radiologic imaging and the lawyer's or attorney's perspective on the invisible injury. So there will be opportunities for question and answer throughout, and we'll take a survey in the end. And if you would like to have a certificate of participation for today's event, we'll ask you to complete that survey at the end. And so we'll get a chance to send that to you digitally. Okay, so let's get started. We'd like to find out, and I'd like to introduce to you our first person. His name is Raul Figueroa. He comes from us from the Public Health Alumni Chapter. There's a lot of words there, Raul. He is the president of the chapter, and he will tell you a little bit about himself as well as the Public Health Alumni Chapter. Before I send it off to Raul, I also want to acknowledge all the people from the CSUN Alumni Association, the board of directors, as well as the people behind the scenes, the staff that are here to help us, the Communication Disorders and Sciences Alumni Chapter, the Education Chapter, the Radiologic Sciences Alumni Chapter, the Attorney Networking Group, as well as the Public Health Alumni Chapter. So, and if you get a chance, please check all our different activities and things that we have available in the future. Okay, Raul, I'm ready. Are you ready?
Ready.
Here we go. I'm going to toss it to you. Here we go.
I got it.
All right.
Oh, I thought you were doing baseball. What's going on here? All right. Hi, everyone. Sorry for the campy joke at the beginning. My name is Raul Figueroa, and as Felicia introduced, I am president of the Public Health Chapter at CSUN, very proud of that. And I'm also a CSUN alumni board member. On top of that, I am an epidemiologist in the field of public health. And so, number one, welcome to the Invisible Injury Seminar. And two, as a public health professional, we always like to know more about our audience and what brings you here. So I am going to ask a few poll questions to get a better understanding of our audience today. All right, let's go. Let's do it. So as you can see, something should have popped up in your screen, and there are a couple questions. It's going to be two. The first one is, which of the following best describes your reason for joining the webinar today? Are you a student athlete, student? We just want to get some work-related knowledge, family member had a concussion, friend had a concussion, or other. So go ahead and pick one of those. And the second question is, what is your field of study / profession? There's healthcare, athletics, education, research, finance, law, or other fields. You will have about 30 seconds to fill out the results. All right, I think we should be able to see the results from the poll. Excellent. 55% of you best describe yourself as students. That's amazing. 27% are for work-related knowledge. 8% know a family member that's had concussion. That's fantastic. And 10 are other. I'm very curious to know what the other is as well. What is your field of study / profession? 57% of individuals are in healthcare. That's fantastic. 23 are in education. And also a few others describe themselves in another field, and a small percentage in athletics. It's very interesting. We're trying to figure out who exactly is participating in this poll. So thank you for that. There's going to be a couple more questions coming along right now as well. All right, so here are the other three questions. So how many of you have had a concussion? You could say, sorry, can I repeat that? It's how many concussions have you had? So the question is, if you had 0, I don't think I've had one, 1 to 2, 2 to 4, 5 or more. The next question is, did you seek medical care if you indeed thought you had a concussion? Say yes, no, or maybe it doesn't apply to you. So you can put the last option, not applicable. And number 3, how long did the symptoms last from your most recent concussion? Did it last for days, months, years? You don't know. Or maybe this question doesn't apply to you. Go ahead and Give it your best shot. All right, so get these results. I'm excited for this. All right, so 55% have never experienced a concussion. Interestingly, 18% say, I don't think I've had one. I personally think I fall in that batch. I may have had one. 1 to 2, 22%, 2 to 4, 3%, 5 or more, 2%. Okay. Did you seek medical care? 22% of individuals who did suffer a concussion sought medical care, with 15% not seeking medical care. Okay. And finally, how long did your symptoms last for the most recent concussion that you had? 14% said that they experienced concussion symptoms for days. Some even had it for months, about 3%, and about 8% for years. Some individuals said 4%, I don't know. Thank you for participating in this. This is very, very interesting. This information is critical for us to be able to better understand the community and what factors and what are some things that the community wants to learn and how to address this invisible injury. Now, I will pass the ball to Rosemarie. Rosemarie, here's my football. You ready?
Ready.
Go.
Good morning, everyone. My name is Rosemarie Hayan Hiron. I am a graduate student in the Speech Language Pathology program at CSUN, and I am currently a board member and tutor for CSUN's NISLA chapter and a student researcher for my program. And now, I am honored to introduce Dr. Felicia Conlan. Dr. Felicia Conlan is a speech-language pathologist for the Los Angeles Unified School District, where she has provided support for students from preschool through high school with communication difficulties. Previously, she worked as a television and print journalist and bilingual teacher. She has presented in state, national, and international conferences on her research on academic reintegration after sports-related concussions. Dr. Conlan serves on the CSUN Alumni Association Board of Directors and has been honored for her volunteer community service and leadership. And now, Dr. Conlan, are you ready?
Yes.
Ready, and here you go.
Okay, I got it. Thank you so much, Rosemarie. I'm going to share my presentation here. If you'll just bear with me for just a second. And I think we're good. So my portion of the presentation is on strategies for return to learn, concussion to classroom. Okay. So as Rosemarie was saying, I wear different hats as an SLP, an educator, and a researcher. But the one hat that I wore, that I still wear, that is most important to me is that of a parent and as a coach. My two sons, unfortunately, experienced sports-related concussions while they were in school. My youngest son, it happened when he was a junior in high school, and it changed the trajectory of his future in college. And my other son, it happened while he was in college. So lightning hit twice in my family, and I guess God has a sense of humor, because here I am presenting to all you folks about the concussions. And so these two guys are my inspiration and the reason why I continue to feel that this particular topic is so important. And I'm so happy to be able to have these friends with us to share this information. So yesterday, as I was preparing for this talk, I went into the browser and just put the word concussion on there. Concussion is a traumatic brain injury, it says here. And years ago when I started this, I couldn't find much about concussion. I had to type in traumatic brain injury. But look at this now, 127 million results just on concussions. So this became a taboo topic. Now there's so much information out there, so it can be confusing to the general public. And, you know, the movie Concussion also was another reason for the public being able to have more information about it. And that came out in about 2015. So it's been a few years. Here are some familiar pictures and movements of what we know about concussions, some of the sports that are involved. There's certainly a lot more than that. So let's get started. Many times people think about a concussion, they got their bell rung or they lost consciousness. We know that that it's more than just that. It's a traumatic brain injury, and the CDC says it's a traumatic injury caused by a bump, a blow or jolt to the head, or a hit to the body that causes the head and brain to move rapidly back and forth. We know that there are chemical changes that occur when a concussion happens, and the symptoms can be cognitive, physical, socio-emotional, as well as a disruption of sleep functions. So my mother, Lynn, was a biochemist, and I spoke to her and asked her to explain to me a little bit more about concussions. So she gave me this visual. Think about the billiard balls. When the cue ball hits the balls, you see them scatter. So the balls can either pocket, they can get hit another one, or maybe not even be touched. So think about that, a concussion as a cascade of events that occurs. And the impact that it creates causes a chain reaction of chemical responses, and any part of the brain can get affected. So when we think about the invisible injury, we can't see what's inside of the brain. It's a functional disturbance, not a structural injury. And the brain needs some time to heal. You see, these neurons are normally firing, and when there's an injury, the brain needs the ability to change and adapt and to reorganize pathways to recover. So in terms of sports athletes, they just want to get back into the game. That's what they're thinking about. You know, many of them think, oh, this is no big deal, and they tough it out. But they also need to get back to school. And sometimes they might be a slow process to get back to learning. Many of you in our audience are students, and so you might be able to relate to this, where the information isn't quite coming in, it's buffering. So the pathway that many athletes think about is they want to just get back into the game. So return to play or return to sport. But it's just as important, the other pathway of returning to learn. More importantly, it's important to return to life and to return to self. So joining these two pathways so that they can return back to their life as they know it would be great. So let's look about return to learn. There needs to be a recovery plan. And it's gradual. It doesn't happen all at once. And it's very important to communicate with the healthcare providers as well as the educational community if you are a student. So avoid activities that place you at risk for another concussion. In terms of the thinking part, it's important to have some rest breaks and look for signs that a person is not doing well if you're the person that is helping to provide care. Cognitive as well as physical rest are important, especially in the first few days. You can do some yoga or breathing, light exercises, meditation can be done, but rest is important. But we'll learn a little bit more about that aspect as we go to one of our speakers. So what are we talking about? Well, you might have difficulty remembering, maybe some dizziness and nausea. Maybe you're more emotional than usual, or your sleep cycle is off. So let me bring it down to you in terms of those being the signs and symptoms. Cognitively, maybe not being able to think clearly or having trouble concentrating. Physically, you've had that headache or migraine and you're sensitive to light and sound. I remember my son was saying that, that he was sensitive to light and the words seems to come off the page. Social emotional, the student might be more irritable than usual, maybe have some personality changes. And lastly, sleep disturbances. They might sleep more or they might sleep less. I recently read an article that children who experience long COVID may experience symptoms similar to those experienced after concussion. So you might want to pay extra attention if that is something that's happening in your lives, that long COVID experience, the brain fog, the fatigue, and memory impairment. Okay, so here are some important considerations. First, the 10 days are most at risk for another concussion. Usually recovering in the first 3 to 4 weeks. The symptoms can appear immediately or delayed. One of the students that I studied was talking about how 3 days later she started feeling off, and so she went and got checked out. And a coordinated effort, as we mentioned earlier, is really important with the school personnel so that academic consequences will be minimized. Lastly, wherever you are, whatever your state or country that you're in, your city, check the laws and guidelines and recommendations. Okay, so the recovery period for a concussion is different for each person, and cognitively, it could worsen if you're not quite healed, if your brain hasn't quite healed, and can interfere with learning, and you might have some additional school absences. Sadly, what we know is that 50% of concussions go unreported. And so unreported means undiagnosed. There might be some students in your classrooms, or you yourself have not reported your concussion or not sure about your concussion. If you're in the schools in the K through 12, other supports might be available to you, the multi-tier systems of support. So that's type of intervention. If you need some additional supports as well, the 504 plan is another thing to consider. And if it's really something that's longer lasting, the individualized education plan. And for those college students who are with us, the Disability Resource Center is another resource. And what we found that students sometimes don't look at the disability resource because they want to kind of tough it out, but those resources are available, and think about it, okay? So this is what one of the students says. It felt like I was like in a fog. I was angry at myself. Something was off, didn't feel right. I'm good at math. The test could have been in Chinese. There was nothing I understood. And sometimes it doesn't always come out when I want to say something. And they also felt that they needed to take more breaks than usual. So you might consider spending fewer hours at school, taking more breaks, receiving help with the schoolwork, or reduce the time on the computer, reading or writing. Students may feel sad or frustrated or even angry because they can't go back to do the sports that they know, or they can't keep up with their schoolwork. So these are some feelings that are common to hear about. When we talk about the invisible injury, it'd be great if we could just take out our brain and just kind of show you, hey, I've been injured. It's not like a crutch or glasses where you can actually see it outwardly. We need to recognize that it is a trauma and that every concussion is unique. Sometimes students may not want to tell you that they have the concussion, or they don't know how to express what they need. So those are some things to consider. Another thing is that sometimes parents or families don't want to pursue medical involvement. They may not have access to medical insurance or medical care. Also, their cultural or religious beliefs either prevent them, or maybe they are a culture that doesn't ask for help, and that sometimes happens. But in the schools, it's important to manage the effects of the concussion and help the student progress academically, even though it is an invisible injury. The circle of care at schools is student-centered. So we think about the home team, the mom, dad, whoever is at home, brothers, sisters, to help, as well as the school team, not only the Department of Athletics, but everybody else that could possibly help in supporting the student academically, as well as the medical team. It's always a continual circle of care, and it's important to continue monitoring that if the student is injured. I just wanted to share this particular idea when you think about concussion management. It's the 4 S's approach, and it was brought to us by Nancy Schlossberg from the field of psychology. The self, situation, support, and strategy. So when someone has been injured, we want to think about an inventory of what has happened and their individualized needs, since it is an individual occurrence. So when we look at self, then we look at what the person's mindset was, or what were their personal characteristics prior to injury. Maybe they have a concussion injury, or they might have been a recreational athlete or an elite athlete. Maybe they had disabilities prior to having the concussion. So those are some things to think about. The other part is the situation, how the person views their injury. Maybe they were the team captain and suddenly he or she's role has changed. Maybe their scholarship hangs in the balance because they're not doing so well in school, or they are not used to thinking slower. Things are happening that they're not able to do. We need to be able to provide the support that's needed, and also for the students to be able to receive that support. Is that support collaborated? Is it coordinated? I mentioned about the Disability Resource Center. There's also a counseling office. What kind of supports are there? If it's at home or at school, who's offering it and how often? When is it available? Also strategies. At what choices do they have in terms of maybe additional supports, either at home or at school, that strategies are helping them. Maybe they've come up with their own compensatories to help adapt and relearn. Okay, so how do you support students with a concussion? I'd like to give just some takeaways that you can think about. When they're processing information, maybe they're having difficulty retaining the information. They're slower at reading or having a hard time following group conversations. So a graphic organizer might help, flowcharts, giving them extended wait time, review, repeat, reread, rehearse, all those re's, so that they can look at the information again. And one-on-one tutoring might also be considered. Here's an example of a graphic organizer. We have the main idea, the concepts, and then details. So the other part is attention. They might have difficulty with attention, maybe easily distracted and needing more time to complete assignments. It's important to take a brain break. So maybe take a physical break from the task. Know what time of day your brain functions best, in the morning or late in the evening, and to minimize the distractions in your environment. One of the students said, just look up. Just going outside, breathing some air, and just looking up helped him. Okay, so another area where you see a problem is in memory. They might have difficulty with multi-step problem solving, retaining information that's previously recalled. One of our students was saying that, you know, the information might as well be in Chinese. It was easy for her to do math, but suddenly she couldn't remember things. So break down the tasks into small, simple steps. Make those checklists, maybe some flashcards, Post-it notes, and sometimes the yellow Post-it note might even hurt their eyes, so you can think of a different one. Use your phone, jot down information right away. You can talk and do an audio, or have a note taker help during a lesson. Okay. The other part is organization. Headaches or decreased ability to cope with stress, create a visual schedule and follow that routine. Resist that temptation to multitask, divide the task into smaller ones, provide maybe a copy of the class notes ahead of time. And then of course, celebrate those completed tasks and cross them off, whether they be something from home or at school. One of the students said sometimes he would forget where he put his keys. So he just put it into his shoes because he needed his shoes to get somewhere. And sometimes he would forget where he would park his car. And I know there's apps now that can help you do that, to pin it. Okay. The other thing is sometimes there are problems with light and sound sensitivity. So they might want to wear some dark glasses or a hat and wear a cap maybe, and to reduce the stimulus and give them an opportunity to maybe to view a recorded lesson, because sometimes those PowerPoints can really affect their eyes. These are some other tips that are available, some other resources that are available to you through the Brain Injury Association. This is rather new. And one other thing I'd like to point out, when we're collaborating today, you know, it reminds me of that fable of the blind man and the elephant. There's different perspectives that we see in terms of this concussion subject. So here we are today, offering you an opportunity to see the world through our lenses, through our different disciplines, so that you can benefit by it. This is a little cartoon. I never played baseball, football, or soccer. I grew up in the concussion era. Well, we know that sports is important for activity, for team, learning how to be a team player, learning signs, the thrill of victory, the agony of defeat. All these things are important. So we want to encourage sports, but we also want people to know that if they've had a concussion, to report it. Returning to learn is important. Returning to play is important. And most importantly, hopefully be kind to your mind so you can return to yourself. Here are some additional resources I'd like to make available to you. All these folks here have just a lot of information, and this is, if you want to take a screenshot of, here it is. And my name again is Dr. Felicia Conlan. I'm a speech language pathologist, and this is my information. Okay, there you go. Hey, Jenny? Whoop. There we go. Okay. Next, I would like to toss it to Jillian. Are you up, Jillian?
I'm ready, Dr. Conlan.
All right, here you go.
Thank you. Hello, everyone. Good morning. My name is Jillian Amber Vista, and I'm a graduate student here at California State University, Northridge. I'm currently in the Speech Language Pathology program, and I'm involved in 3 research projects in my department. Now, I'm honored to introduce Dr. Nancy Cohick. Dr. Cohick is a professor at California State University, Los Angeles. She's a certified speech-language pathologist with experience in school and hospital settings. Courses taught include anatomy and physiology, neuroscience, neurological disorders in adults, dysphagia, and motor speech disorders. Primary research interests include concussion education for athletes and treatment for cognitive communication impairments. All right, Dr. Cohick, are you ready?
I'm ready. Thank you so much, Jillian, for that lovely introduction. And I wanted to give a quick shout out and thank you to Felicia and Jenny for organizing this amazing panel today. And thanks to all of you for being here on your Saturday. It's gorgeous weather outside, so we appreciate your time with us today. I guess I'll share my screen. That would be helpful. All right, can y'all see that, I think? So as Jillian said, I'm a professor at Cal State Los Angeles, been there for quite some time. And no matter how long I present or how many times I've done it, I still get nervous, just like all of my students do. So I'm honored to be here. I'm going to, I don't have any financial disclosures, but I do have a non-financial relationship with the Concussion Legacy Foundation. I use their presentation for educating high school athletes. I too put up a little comic here, so I'll give you a second to read that. And I thought it just kind of hit home with the topic today. So for those of you who are speech therapists out there, maybe you can throw into the chat, what's the impairment going on here? See if we get any responses. What impairment? What's the problem here? They obviously, thank you, Lisa. Yes, memory is the issue here. And certainly we all know that is a potential factor in terms of long-term impairments following concussion. Today, I'm going to focus on a few different things. ASHA, which is the American Speech, Language, and Hearing Association, that is the governing body for speech pathologists and audiologists. So we're going to talk about their perspective on prevention. How many speech therapists are in the room or in the audience today? Again, feel free to just pop it into the chat. You can say me, yes. See one, thank you. Oh, we're getting a few here. Okay, so we've got some current and future SLPs. Wonderful. Well, thank you all for being here. We appreciate it. So, you know what ASH is, and we'll talk a little bit about the scope of practice. I'll also touch on some of the state laws and concussion education requirements, as well as the Concussion Legacy Foundation's program. So just quickly delving into the scope of practice here, there are 8 domains in our scope of practice. And as you can see, that third one is prevention. We also have 5 domains of professional practice, and you can see here that education is one of them. So let's take a closer look at this document. And the first sentence here talks about prevention. And I really question, you know, I work with adults and we talk about strokes. Can we really prevent a stroke from happening? I think that's really debatable. Certainly there are things that we can control, like smoking, like our diet. Are we exercising? But there's other factors that we have no control over, like genetics. Sadly, our age, we have no control over. But when I work with a client who's had a stroke, I do talk about these risk factors, and I ask them if there are things they can change that they can control. Now, I am in no way suggesting that we can prevent a concussion. And in fact, if you choose to participate in sports, the likelihood of an injury is probably pretty high at some point during your sports or athletics career. But what I am suggesting is that we can educate our athletes and prevent them from having a more severe injury. So if you have a concussion, you have symptoms like Felicia mentioned, and then you go back into a sport with having those symptoms, they have not gone away, and you continue to play, you're putting yourself at risk for second impact syndrome. And this is the piece of information I'm trying to get out to our student athletes. So I'm going into the community, talking to these high schoolers to try to help them understand the seriousness. If they just tell somebody that they feel off, or they have a headache, or they're in pain and refuse to go back in the game, they're going to help themselves from having that more severe injury. Second impact syndrome is preventable. The other thing I wanted to talk about is the education piece. ASHA specifically talks about educating parents, but nowhere in this document do they talk about educating the athlete who's playing the sport. And to me, that's who I've been targeting. We do invite parents to come and listen to the presentation, but unfortunately, we present at 4 o'clock to meet the needs of the students, so it's right after school. And many parents cannot get to the presentation because of their work schedule, which I completely understand. So that's something that we're working on. I do have another little poll for you. So again, you can just put it into the chat. In the audience, are there any high school speech language pathologists listening today? Again, you can just say me. Lisa Lennox, thank you. Rita. Amy is. Okay, so we have a few who are working in the high school. Okay, and some of you are doing student teaching. So I ask this because you are the perfect person who could help spread the word. You too in your own schools can do this education program that I'm going to be speaking about today. So before we get there, I'm going to briefly touch on some of the concussion laws. I'd like to mention Zachary Lysted's story because he had 2006, he was playing, I want to say it was like a Frosh-Soft game, had a major injury. He was taken out of the game, but at halftime, he went back into the game, despite the fact that he still had pain and was suffering headaches. He did not tell anybody. He did finish the game, but immediately following the game, he collapsed on the field. He had horrible visual issues going on and just a pain level that was intolerable. So in Washington, they had the very first concussion laws. And following that, about 6 years later, all of our states across the nation have some type of concussion laws. Now, exactly what that is varies. And you can see most of this map is in very, very light blue, and they have no minimum timeout requirement. There are several states in the baby blue that you cannot return the same day. But if you're in practice on Thursday afternoon and you have a game on Friday afternoon, there's a chance if you have an injury on Thursday, you could be going back into play in less than 24 hours. These two states say, nope, you cannot go back at all for 24 hours. And then the more stringent states, including California, you see with green, and the STARS. These states actually have additional restrictions that require physicians to clear the patient or the client, athlete rather, to go back into play. And they have to do a graduated return to play protocol. And I think Brittany, our athletic trainer, might be touching on that today. So you have these in the slides that you'll be receiving later. I'm not going to talk about all of the details associated with these, but you can see there's been an evolution of the state laws. In 2014, this graduated return to practice, that's when that came into play. And then also coach training about concussions. So coaches are required to be educated about concussion, or they're supposed to be given information to educate themselves. Now, the follow-through piece is what's missing. We don't know if these coaches have actually executed the concussion education piece of it. In 2007, all of these sports probably look familiar to you. This law was extended to youth sports organizations. So if you yourself ever played AYSO, Friday Night Lights, extracurricular basketball programs, they added rules to those. And what that included was that anybody 17 years and younger, parents had to be notified if that athlete had a suspected concussion. Did not have to be confirmed, but let's say, they had a fall, they hit their head-to-head contact, they had to be notified. Also, this is when that concussion education requirement came into play. Coaches are supposed to be offered this by the administrating governing body, so AYSO, softball leagues. Whether or not they are doing it is another question. Also, athletes and parents are supposed to be provided with a concussion information sheet, which we'll look at. And then they do have to follow those removal from play and return to play protocols. So what are those 27 sports? It's a pretty big list. And I suspect many of you out there have played some of these sports. Anybody name the top 3 for injuries in terms of concussions? What do you think's at the top? Throw it into the chat for me. Football is up there, not number 1. Soccer. Hockey's a big one too. Less so in California because we have less high school hockey. But excellent, you guys, you're on top of this. Oh, rodeo. Here's your equestrian activities. So yeah, top of the list is definitely soccer. I believe hockey is up there. There's a lot of competitive cheerleading injuries that can happen too. Thank you for your responses. Oh, well, that was my poll. Haha. I do have another question. How many of you have participated in those sports? At any point in your life, have you played one of those sports? I'm guilty for synchronized swimming, but soccer, swimming, some no's, cheerleading. Some, Valerie says she had soccer and sustained a concussion, softball, lacrosse. Okay, so we've had a lot of you playing those. And I was going to ask you some concussion questions earlier. Raul actually did a poll at the beginning, but I'm going to ask one more question. So of those who just said, yes, I played, if you had a concussion, did you tell somebody? Yes, I told somebody. No, I didn't. If you had a concussion when you were playing those sports, did you tell someone? Valerie said, yes, she told someone. No concussions. Yes, took yourself out of the game. Awesome. Elizabeth said she did not tell anybody. And Lauren says, yes, she told someone. Haley as well. That's awesome. I think we have come a long way in terms of getting the word out and the importance of not hiding concussions. Thank you for participating there. I want to mention what the coaching education is. So most of the high school coaches are sent to the National Federation for High School Associations. There is a website where they can go and do a concussion training course. I highly encourage this for parents and athletes as well. Very easy, it's free. It's an elective course, as you can see here, so there's no follow-up as to whether or not the coaches have actually done this. Here's the one for students. Again, you can see that it's an elective course. Now, I am going into LAUSD. That is where the 4 schools that I've been working with are located because I'm serving around Cal State LA. So if you look at the sheet, this is page 1. This is page 2. There's a lot of information on these pages. And then the third page is the signature page. So both the student and the parent are supposed to sign it. But I don't know about you. I do have a daughter, school-age child, and she sometimes forgets to tell me I need to sign things. And so then in the morning of, when she needs it, Mom, hurry, you need to sign this. I'm going to get in trouble. I'm going to get in trouble. Well, I suspect that's often happening with this. So even if the parents are receiving the information or the student athlete is receiving the information, I truly question how much they are reading it, first of all, and how much they're understanding it. There's a lot of good information here. You know, why am I getting this? How would I recognize a concussion? They actually even talk about second impact syndrome here. But again, is the person reading this, the high schooler or the parent, going to fully understand what this means? So that's what prompted me to look into doing face-to-face concussion education programs. And I actually did my first one over 10 years ago in 2013. Well, I guess it's almost 10 years. It was okay. We saw an increase in change in knowledge about what the signs and symptoms, what they should do if they think they have a concussion. But what we didn't see a change in was concussion attitudes. And that's actually because there was a ceiling effect. They already had a pretty good attitude about concussions. Unfortunately, this was not one of my better presentations. It was really boring and dry. And I wanted to find out a better way to connect with the students. So I took some time off. I did some research, and I ended up with the Team Up, Speak Up program from the Concussion Legacy Foundation. So I spoke with the director there, and they allow people to use this program. They want to get the word out. So it's a preset concussion program that has an evidence base for it. And their research revealed that 93% of students agreed or strongly agreed that because of this presentation, they'd be more likely to tell a coach or a friend if they thought they had suffered a concussion. They also learned that 89% of students agreed or strongly agreed that because of the presentation, they'd be more likely to tell a coach if a teammate has a concussion. So if you think your friend got their bell rung and they're not telling somebody, this is telling you to speak up for your friend. It's okay to share. And in the end, you're probably going to help that person. So the program is set up into 3 parts. The first part talks about what is a concussion. The second part talks about why it's important that we understand the consequences of concussion. And the third part talks about what to do if it happens. And I like the way that it's set up. I recruit students from Cal State LA to speak on parts 1 and part 3, and I do part 2. But the logistics behind this, it's really challenging scheduling wise, because I have students who have classes, I have my own class schedule, and then we also have the school schedule that we're working around. So really, to make this work, I need at minimum, ideally 10 different people trained on part 1 and 10 different people trained on part 3. And we're literally just getting our feet wet, trying to get back to presenting this coming fall. The first time we presented was the academic year 18-19. Everything went great. We had people trained to go in for 2019 and 2020. We got the fall presentations done at a couple high schools. And then spring, everything was canceled, unfortunately, due to COVID. So it's been a long time since we've been out there presenting this. But I want to give you an idea of a little bit more about each of these parts. So in the first one, part 1 is the basics. There's an excellent TED Talk that was designed for the Concussion Legacy Foundation that talks about what a concussion is and the biomechanics behind it. And then we ask for student volunteers. So we have 2 students come up from the audience, and we have a set of index cards that we make, and we show one of the students what the symptom is, for example, loss of balance, and he acts it out, and then or she acts it out, and then whoever comes up with them, the second volunteer is guessing, and they alternate acting it out and guessing. So for loss of balance, they're usually pretty silly, and they'll walk and they'll fall on the floor, and it gets good laughter from the audience, so I know they're engaged and paying attention. And so the signs that we go through include those that Felicia mentioned: loss of balance, nausea, loss of consciousness, headaches, blurry vision, confusion, memory loss, and sensitivity to light. So that gets a lot of laughter and engagement. And then this part also has, we have 2 different other volunteers come up. They toss the ball to each other with no concussion goggles, but then we put on prism-like goggles to simulate the effects of a concussion. And you can imagine throwing the ball. Well, now the receiver is not quite able to catch the ball. Part 2 looks at testimonials. There's many different testimonials. The first one is Brianna Scurry. She was a world famous women's national soccer team player. She suffered a lot of concussions, and she talks about how the final one impacted her and affected her daily life. And then we've got 2 high schoolers who talk about their injuries. This is Noah, and it's a video sharing about how he had 7 documented concussions, but he had an additional 7 that were never, ever documented. And he talks about his major concussion that he had sustained during his football experiences. And they had to leave the state and go find a specialist in concussion because he couldn't understand what was happening and why his academics were affected. And then we also have Esther, who talks about how she had a major soccer injury, a concussion during 8th grade, and how that affected her. She was out of school for a year, and she talks a lot about the strategies that she has to use and how much she had to work to come back into play. And these videos aren't meant to scare the athletes, but they're meant to really connect with the athletes. And I do think it achieves that goal. And it leaves an impression, just, helping them to remember they really do need to talk to somebody. The last part addresses the importance of recovery and the need for teammates to look out for one another. It touches on some of the reasons why athletes choose not to report their concussions. There's a few more will pop up, and Felicia touched on some of these as well. And it also has some examples from the National Football League. There was a news clip after Brett Favre had a pretty major injury, and one of his teammates, Donald Driver, came over to him and talked to him, just kind of talking about, this game is just a game. Your life is much more important than this game. So he was speaking up for his teammate, trying to help him to make the right choice, and he ended up leaving the game. There's also a video. There's a video that is shown with head-to-head contact of soccer, a girl down on the field, and how the teammates work together to help her. So in addition to the few that we mentioned, there's a couple others on the slide as to why concussions don't get reported. It's just not happening enough yet. I think we're seeing a gradual improvement, and we're almost there, but we're not quite there. So ultimately, I've presented at 4 different high schools. As I mentioned, we're just getting our feet wet. I've contacted all 4 schools. 3 out of the 4 responded right away and are up and ready to get going for the next academic school year. Actually, July will be our first presentation. But the big challenge that I mentioned is I just don't have enough people to get the word out. I would like to reach 2,500 schools, but right now I can only manage 4 schools. So I'm reaching out to SLPs like you and professionals like you. If you're an athletic trainer, if you're a nurse, if you are in a school in any capacity, you have the potential to reach students. You could work as a team together. If you're in a school district, you could have 3 school therapists from different sites working together and going to each of those sites to do a concussion education presentation. So really, it's just manpower. And I've been fortunate with Felicia to make some connections. I have done 1 training and would love to reach out and train more of our professionals. So thank you all. If you have additional information, you can reach me at Cohick at Cal State LA. Felicia, are you ready for the ball?
I'm ready.
Here it comes.
Got it. Got it. Thank you so much, Nancy. Lots and lots of information. Okay, I'm going to toss it right away to our next speaker, actually to Samantha Tan, who was my former graduate student and is now a professional speech language pathologist. So Sam, are you ready?
Yeah, I'm ready.
Here you go.
Okay, I got it. So my name is Samantha Tan, and I'm a speech language pathologist who works in a private practice. I'm also a CSUN alumni, and I was very fortunate to have worked pretty extensively with our next speaker. She probably helped me with a few too many injuries during my time as a student athlete, where she was the CSUN club head athletic trainer. She has extensive experience working with and advocating for both College Club and K through 12 athletes. She is a national leader in the National Intramural Recreational Sports Association and has spoken at conferences on the topic of sports-related concussions. And it is my pleasure to introduce my colleague and my friend, Brittany Bingham. So I'm gonna toss it to you now.
Thanks, Sam, and thank you everybody for being here today. I'm going to share my screen with you. Okay. So like Samantha said, I'm a certified athletic trainer. I have over 14 years of clinical experience, working at anywhere from Division I to sport club level, and currently work at a high school here in Ohio. My greatest achievement, though, is that I can proudly say I was the first and the originator of the athletic training program for sport clubs at CSUN. So I'm pretty proud of that. That's my pride and joy there. And then I have taught over the last 10 years at a couple different universities. Most recently, I was at Boston University, where I was fortunate enough to work with their master's program for athletic training. So what is an athletic trainer? An athletic trainer is a highly qualified, multi-skilled healthcare professional that's specifically trained in the prevention, examination, diagnosis, treatment, and rehabilitation of emergent, acute, and chronic injuries. Notice I did not in anywhere mention there that it was only sports medicine or sports-specific injuries. You can find athletic trainers across the board in many different healthcare backgrounds and different settings. But in this immediacy, most of you guys should be seeing athletic trainers in the sports world. The biggest thing that you need to know about athletic trainers is that our scope of practice can vary a little bit by state to state. And for you California people, I hope this shocks you as much as it's shocking to us as professionals. 49 states in the US require some form of state licensure, certification, or registration as healthcare professionals. One state does not, and if you guessed California, that would be the state. So technically in the state of California, anybody and their brother could walk up to a sideline, identify themselves as an athletic trainer, and diagnose somebody or assess an injury, say they have, I don't know, a concussion, and provide them health care that is technically not illegal because, again, there's no state law in California in regards to who can identify themselves as an athletic trainer. When it comes to our role in concussion care, ideally, there should be an athletic trainer on the sideline at any high-risk sporting event, hockey, football, soccer, lacrosse. We should be present to be able to immediately evaluate the injury, make sure that the athlete is being removed from play. Again, backing up what Nancy said, enforcing those state laws, usually removing them from play for 24 hours until they can follow up with a healthcare professional who's been identified as the clearance or the person to provide clearance. In our case in Ohio, it's our team physician, general practitioner, family doctor can clear them. And really, as we move on, and I'll talk about, we should be driving the ship when it comes to helping our athletes navigate their post-injury healthcare. Where should they go? Where their referral process is? Are they having lingering symptoms? Is this affecting them not just in their sports, but also in their education? So, and we'll talk a little bit more about that role in a second. So, if you're not sure whether or not the school that you're at has an athletic trainer, the Atlas survey has been created, and you can go to this website and you can look up the state of California, and you can either type in the name of the school, or you can simply do a general search in your area or location and see, do you have an athletic trainer? Is there a full-time athletic trainer? Is there a part-time athletic trainer? Is there no athletic trainer? Once you pull it up, you can look and find a school, and it'll tell you, okay, what is the contact information for that athletic trainer, about how many students are there, so you can get a little bit more information about what that school provides. And I think that's very valuable information. If you have students or your kids are going to that school, I personally would want to know if there is an athletic trainer, but also from a sport perspective, do they have care? Is it being provided, and who's providing it? Unfortunately, California is one of the states where less than 50% of the high schools have some form of provided medical coverage on the sideline. So when we talk about concussion, there are many definitions for concussion, right? And it really depends on your practice that you're in, that you pull it from. And those definitions always have common terminology: force, direction. We always talk about signs and symptoms. Is there a loss of consciousness? There doesn't have to be loss of consciousness for them to be considered concussed. You know, we may talk about neurological impairment. But what I really want us to understand when it comes to that concussion definition is that we have to rely on the definition that our athletes and our parents and the general population is going to look up. They're not looking in medical journals. They're not looking up, you know, what is our National Athletic Training Association describing a concussion. They're Googling, and this is a Google screenshot, what is a concussion? So the very first definition says that there's an unconsciousness, but we know that athletes can have concussions without losing any form of consciousness. So already we have conflicting information being given to our general population. I find that when we talk about concussions and identifying concussions, because of the history of concussions, the term doesn't carry as much weight when we say someone has a concussion. I still have coaches to this day that I say, hey, this kid has a concussion. They need to follow the protocol. They need to see a physician. That the coach will go to me, oh, they just got their bell rung. It's 2022. We don't say that anymore. We don't say they got their bell rung. We don't say they just need a breather. They just need a break. That's not how we do it anymore. And so I actually would really like to see a shift and a better adoption of utilizing TBI and traumatic brain injury, because I feel like if we use TBI as the definition instead of just concussion, it adds a little bit more weight, a little bit more gravitas to what we're talking about. And I almost question, would my athletes then take it a little bit more seriously? Well, no, it's not just a concussion. You have a mild traumatic brain injury. Maybe it will draw the parallels to that a little bit more, that they need to take this more seriously, and that it may impact them at a greater, have a greater impact than them just thinking, that's a concussion, I'll be back in a week, it'll be fine. So let's start from the beginning. When we're evaluating or we have a concussion happen, our athletic trainers are on the sideline. Hopefully that's who's evaluating them, if we're really lucky. And then they're going to be the referral source. We're going to get them out there. We're going to get them to doctors, the people that they need to see at the schools to get them taken care of. They may not see an athletic trainer. They may see a school nurse 3 days later because they've had headaches all day and they can't focus in class and they don't feel well. And they, knocked heads with someone at a soccer game 4 days ago, but they're really struggling in school. So then the school nurse becomes the referral source or the initial contact person. The parents themselves may just notice that their child seems off and, hey, you know what, we're just going to take them to the pediatrician or our primary care physician. And the problem with all these various people who are diagnosing is that we don't really know what level of understanding and education they have when it comes to concussion. How current are they on that level of education and what the appropriate recommendations are, especially when we start talking about our long-term impairments or our people who don't follow that typical recovery pattern. So we talk about the concussion care team. I'm going to talk about the secondary school setting first. We have our athlete. Our athlete sustains the injury. Hopefully they report it to the athletic trainer. That's our first direct link of communication. The athletic trainer is going to make sure to communicate with the parents, okay? And when you work in the secondary school setting, they're under 18. Even when they're over 18, the communication always has to go through the parents. So you're very limited in your decision-making process to make sure that the education of the parents is key. And because everything has to go through the parents, my direct access may or may not be with the physician, depending on who they take them to. The physician, like I said, may talk to me, may not talk to Again, it's on the parents and the athletes to talk to the school administrator. So if there's no concussion protocol at the school, who's in charge of making sure that this athlete gets the accommodations that Felicia talked about, that they get that return to learn process, so that they can adequately overcome their symptoms and recover and be able to get back to their self. And then again, the school administrator, it's on them to communicate with the teachers and saying, hey, here, you need to make accommodations for the student. Well, the teacher has 7 periods and has 28 kids in each class. They have to then make accommodations for one student, depending on how well versed they are and what those accommodations look like. They may or may not be able to actually accommodate that athlete's needs or that student's needs. So then what are they actually getting out of school? Are they getting the attention they need? Are they able to be present in school, or are they just exacerbating their symptoms? And it just, again, it's a bigger problem. It's just very unidirectional when we talk about the communication. Okay. Here's an ideal secondary school setting. We have the athlete, they get injured, report to the athletic trainer, we have the parents, we have good communication with the physicians. And this is what we really want to see moving forward in our concussion care teams, is that there's some form of established concussion care team on the school side, made up of the counselor, teacher representative, hopefully the school nurse, and ideally we would like an SLP present, because they're going to be the ones that are going to help us with those accommodations and those recommendations of how we can get the student the resources they need in order to be successful as students. And ideally, we've got that communication going across the board, right? When we talk about the collegiate setting, it's a little bit different. We have no parents. So yay in some ways, because now I can directly talk to the athlete. I have a team physician. I got Dr. Sletten, who I can call up and be like, hey, you saw so-and-so today. How are they looking? What's our plan of care? Where are we going? We have that direct communication, which is great. NCAA has academic advocates. Those are the people who are going to reach out to the professors, and they're going to make sure that they're getting the accommodations that they need in terms of, hey, you need extra time for a test, let's get it done. You need, you need to stay out of school for a couple of days. Okay, let's get that excused absence taken care of for you. So it's athlete centered, but there's good communication all around and good support that's already established. And then we throw the coach in, and we should have good communication with the coach, but he's more of a peripheral member of the team and really just communicating in terms of when they get back to that return to play status. And then here's the least recognized members of our academic athletic community, the sport clubs and the recreation and the kids who play intramurals, who may or may not have an athletic trainer, may or may not have any medical resources whatsoever. Hopefully they have a student health center that they're able to go and get seen at and get some referrals and help there. And then they got to go and talk to their professors, and it's on them to talk to the professors. And if they're lucky, they have a disability resource center, and maybe the disability resource center has some established guidelines that may or may not help them to create those accommodations that that academic advocate would for that NCAA athlete, but that may not always be the case. And I know in a lot of cases with the Disability Resource Center, there has to be an established timeline of recovery or an established timeline of when those services will be administered or given, that in a concussion, we may not be able to do, because they could feel better in 3 weeks, they could feel better in 3 months, they could feel better in 3 years. So it creates some other issues, but the biggest one is that we put the burden on the athlete to manage their own care while both physically and mentally impaired. And they really do, unfortunately, get the shaft when it comes to the care. So we talk about concussion recovery. The typical recovery is on average 7 to 10 days. Okay? The initial injury occurs. Within the first 3 days, we're encouraging them to see the physician and establish some form of testing baseline with the physician. By day 7, most, if not all, of their symptoms will have subsided. And then usually once the athlete's been asymptomatic for 24 hours, they'll begin their return to play protocol. The athlete once they've completed the return to play protocol, and most return to play protocols are on average about 5 days, then we consider them to be recovered, healed, however you want to put it, ready to go, and they go back to play, and we think they're hunky-dory, and go team go until you get your next one, or hopefully you don't get another one. Okay. This is generally, I would say, probably 70% to 80% of the concussions that we deal with follows the recovery pattern. Okay. Where we see issues arise is when we get our atypical recoveries, where the athlete sustains the injury, and then usually they see the physician again. So we're getting, again, the same referral process, but their symptoms don't recover as quickly as the individuals who have a typical recovery. You could have symptoms anywhere from 1 month up to a year, if not longer. And when we talk about the atypical recovery, what we generally tend to see is that it's not something that impacts their physical abilities. It impacts their education, their cognitive, their mental abilities. And so we generally tend to see with the atypical recovery, they're struggling in their classes, they're struggling with depression, they're struggling with anxiety. We see a lot of these life-altering symptoms that, again, they can go and jog and they can go and ride a bike, but we're not seeing the improvement for them on the cognitive side. And that's really important, because when we have that atypical recovery, how are we referring these individuals? You know, understanding that we have to have a team approach, but when we talk about that team approach, how many of our patients and our parents actually know half of these specialties? Do our general practitioners know that they can refer to half of these specialties? I did an observation with the director of the Concussion Care Clinic at Boston Children's Hospital, and when he would give out information about the Return to Learn program to his atypical recovery athletes or individuals, he would often say, take this to your school, here's your recommendations. And I would ask him, well, aren't you going to give them more? And he's like, well, why would I give them anything other than this? I don't have an education background. I don't know what to tell them. Like, this is all I know. And I said, well, what about SLPs? Why don't we bring some SLPs into the mix and help with the education side of things? And the director of the Concussion Care Clinic goes, what's an SLP going to do for me? And that blew my mind, because as the Concussion Care Clinic director, he doesn't even know what other referrals and specialists are out there that could help his patient recover and return to their normal and their daily life without impairment. And so it really emphasizes that this team approach, while important, if we don't know, and we don't know how to refer, and we don't know who's driving this boat, then how are we going to get them the care that they need to recover faster? So what is it that we're doing right in concussion care? Well, we have state laws, which is fantastic. All 50 states, you're required to remove from play. Most of them require 24 hours to allow you to come back, as long as you're cleared by a healthcare professional. We're seeing changes in youth and sport rules and laws. Football kickoff rules are changing. As of 2018, they showed a 35% decrease in concussions on kickoff plays from 2017 to 2018. Huge. Talk about the Oklahoma drill. It's been banned in the NFL and at the state level due to the high risk of injury, especially for concussions. Soccer, no heading under 10 years of age. Reduced contact exposure for heading from 11 to 13. Hockey, they don't begin full body contact or body checking until 13 or 14 of age. So we're allowing for development of the brain before we start exposing it to these high impact or at risk forces, which is great. So we're doing things well. We're requiring education for students and parents and coaches that are requiring them to understand, what is a concussion? How do I identify a concussion? How do I report a concussion? So we're doing better there. We have standardized testing. The SCAT-5, a basic sideline test that healthcare professionals can do to recognize an athlete who may be suffering from a head injury. And majority, if not every single physician across the country, should be familiar with the SCAT-5, so that if I send an athlete to the physician with the form, they know exactly what they're looking at and what it's telling them about that athlete and what impairments they might have. We're utilizing impact testing, which is the cognitive computer-based testing that helps us to identify when an athlete who says, yeah, I'm asymptomatic, I'm feeling great, can return to play. Well, you may think that you're okay and that you can return to play, but when we do this cognitive computer-based testing, a little more objective, we're seeing that you're not even close to your baseline. There's some recovery that still needs to be happening there, even though you may be identifying yourself as asymptomatic. Okay. But here's where we fall short. Our society is really focused on equipment. How can we improve helmets and fancy new sensors and all these new equipment options to reduce risk or prevent, we use the word prevent concussions, which, okay, yeah, it's attractive, it's sexy, it's, hey, let's put this really great, awesome 3D sensor on your helmet and try to use this data to show that we're preventing your injury. But the problem is we can't even identify the biomechanics and the risks of how people are getting concussions in a controlled, laboratory setting, let alone with all the variables in a sports setting. So this going out and buying a $500 Rydell helmet that has a sensor in it that's going to tell you when your child gets hit with a force greater than, X, that's great, but it doesn't tell us anything, and it doesn't actually help us with preventing the concussion or preventing or reducing the risk of the concussion. The focus is always on sport. We have so much emphasis on, hey, let's get this athlete back to play, get them back to play, get them back to play. Why isn't the athlete back on the field? And I think that we have to remind ourselves that these are student athletes. They're 16, 17, 18 years old. In my case, I have junior high. They're young, and they're not, they're getting hit, multiple hits, 5, 6, 7 concussions. And again, we're focusing on sport, not the rest of their life, their ability to function day to day, to sit in class and take in the knowledge that they're supposed to be learning. We are seeing a lot more people who are falling under the radar when it comes to prolonged recovery. How are we recognizing these individuals who are at risk? And again, going back to that referral process, how are we educating the parents on what is available to them with their resources? What does their insurance allow for them to refer to? What might their student need in terms of that expanded team dynamic to help their student recover? And then here's where we're going, right? We're talking about biomarkers. How do we get that objective diagnosis of, can we do a blood test? Can we test their spit? How do we do something that doesn't require the athlete to give us a subjective answer on how they're feeling to diagnose whether or not they have a concussion or a head injury, okay? I think that the education and return to learn programming has to improve across all 50 states. If you're in Colorado and you're in Philadelphia or Pennsylvania, you have a state program for return to learn, and that's it. We got 2 states that are doing it, and it's just not enough. And lastly, I really think there has to be a grassroots education program at the youth sports level. I think we have to get to these youth soccer associations, these USA Rugby, where they're recruiting them at 5, 6, 7 years old, and really focus on educating them younger and not waiting till they're in middle school or high school to educate them. And that's it. So thank you, fellow presenters and the CSUN Alumni Association, associated students. That's my bread and butter back there, and my CSUN Sport Club alums. So Felicia, I throw it back to you. Did we lose Felicia?
I got it. Had to go a long way to get it. Way back there. Thanks,
Ohio,
Brittany.
California.
All right, we're going to take a quick poll because we have some myths that are out there. And I know, Brittany, you're going to help me with that. So let's put that up. Okay, some group interaction here. Concussions must involve a loss of consciousness. True or false? Helmets and mouth guards prevent concussions. True or false? I'll give you a few seconds. All right. Let's see what false, false, false. Okay, we have a learned group and audience here, Brittany.
I love it. I love it.
The answer is false. Way to go, everybody. Great. Okay. Does anybody have any questions? We're going to open up just for a question or two. If anybody has anything, please put it on the chat. Let's see, the one about MRIs and CTs, that will be discussed later on when we talk about the radiologic imaging. And I think the other ones were answered. If you could put on the chat there, just something that you learned this morning, that would be great. Put it on the chat. What have you learned or heard today so far that you feel is important? Let's see. We will get back to that. I'm here. We have a, oh, wow, that's going really fast. Someone's got to help me out here. Team approach is important. There is training coaches must do for concussions. The importance of a school team. Excellent. The state laws or something, TBA and concussion are there is a difference between them. Okay. So we are going to, team up, speak up. Oh, there's a lot of stuff. I am so glad you guys are getting something from this because we all worked really hard to get this information. There's so much going to come ahead as well. Okay, Jenny, I think we're going to take a quick break so that we can get Aaron ready. He'll be next. So we're just going to take 2 minutes, take a stretch break, a brain break, a water break, or whatever it is, and then we'll be right back. Thank you, everybody. Okay, well, welcome back. I know there's some audio in that, but it didn't come out, so that's all right. I would like to toss the ball next to Jillian. All right, Jillian, how are you doing today? Oh, it's Rosemary. I'm sorry. It's Rosemary. I'm so sorry.
No problem.
Rosemary. All right, are you ready?
I'm ready.
All right, here you go. Whoa.
Thank you.
All right.
I am happy to introduce our next speaker, Erin Weinstein. Darren Weinstein is a performance consultant for athletes and lecturer in sports psychology for the Department of Kinesiology at California State University, Northridge. He has worked with collegiate athletes for the past 7 years and recently published a book on mental side of baseball called The Baseball Brain. And Mr. Weinstein, are you ready for the ball?
Yes.
Here we go.
Got it. Just like old times, right? All right, let me share my screen with everybody. Okay. Well, I am really excited to be here with all of you today, okay? So again, my name is Darren Weinstein, and why I'm so excited is, I grew up in the San Fernando Valley, and I've been teaching at CSUN in our kinesiology department since 2013, okay? So my background is really in sports psychology, but what I also do is act as a performance coach for athletes. And so as she said, I was able to do this with our baseball team on campus for 4 seasons, and I ended up turning that information into a book, which you see here, called The Baseball Brain. But how I really wanted to start out with all of you is I want to give you a little bit of a glimpse into what my role may experience when I'm working with an athlete, okay? So what are some of these basic issues that we see? And I broke them down into these different domains for you, okay? So mentally, issues getting over mistakes, concentration issues in practice. Maybe I'm going through a slump, or I just can't handle pressure well enough. Well, these are all very basic performance issues that most athletes are going to go through at some point in their career. And these are especially what I talk to a lot of athletes about, where we come up with different skills to try to help them through these issues. Now, emotionally, what may they talk about with me? Well, maybe I'm worried about losing my scholarship, or I've got some bad grades coming down the pipe, and I'm really concerned that I may not be able to be eligible for the team. Perhaps there's some relationship issues or family problems that are happening, or support system struggles. And I have a picture up here of Michaela Schifrin. This is an athlete who has just recently performed in the Winter Olympics, and she's a multiple-time gold medalist. And this Olympics specifically, she struggled a bit. And she talked about mentally how, I've never made these mistakes before, and how because of that, I'm having a hard time getting over them. But then when you also hear her talk about the emotional side, her father passed away a couple of years ago, the first Olympics that she has not been a part of with him. And so you start to put those pieces together, and this is basically what I, in my role, end up discussing with a lot of these athletes about, okay? Now, what I also hear, even though, yes, I'm in the psychology domain, they are going to bring up other things, especially even related to the physical side. So maybe they have some sleep issues that they're going through, which I'll talk a little bit about. Nutrition habits are off and they're not eating well enough, or maybe they're even just playing through a minor injury. This happens all the time, and that's also something we're gonna touch on in a couple of slides here. But a huge aspect of what I discuss outside of even the mental side is the social side, okay? So maybe there's issues with the coaching staff and they're getting screamed at too much, like you can see here in the photo. Maybe there's some problems with teammates that they're going through, or, especially what I saw is this is the first time I've ever been away from home. And so, I've got to make all new friends and I've got brand new teammates. So these are the normal things and issues that an athlete may go through and experience, and that I might talk about with them. But now I want to throw in an injury into the equation, such as a serious concussion. And I want you to notice how all of these domains completely shift, okay? So mentally, what starts happening? Well, instead of worrying about getting better and tweaking things, now there's almost like this full shutdown where they stop getting better, okay? And the reason is because in their mind, well, if I can't play, then I don't need to really practice. And so they automatically start getting worse mentally at their sport. This leads to a loss of confidence. And what you also see is they struggle with motivation. It's one thing when you're getting up, working out, hard every day and getting up early in the morning because you're going to be playing sports. When that is taken away, now they have to find new motivations to get behind. And this can be a struggle if they haven't really had experience with this. Now, what are we going to see emotionally? Well, mood changes are going to start taking over, okay? They're going to be very agitated and anxious and frustrated. They could experience some fear of maybe I'm not going to actually recover from this injury and be, what I used to be. And especially when we see a total loss of their sport and it's taken away, severe depression can set in, okay? And so this is also something we're going to be discussing here. Now, what happens in the physical and social side? Well, physically. They're going through daily pain now. This isn't something they were dealing with before. But something that isn't considered enough is their exercise outlet gets removed. So you have an athlete who's accustomed to working out almost every day, some type of physical exercise, and now they almost do nothing. And so that is a very dangerous situation, and that can cause a lot of different chemical changes also. But something that I experienced, and I think this is an important point, is I can't tell you how many times this happened. You know, maybe I was at a game, okay, or practice, and there's an injured athlete who they can't practice and play right now, but they come to watch. And so I would see them on the side, and I go up and, say, hey, how are you doing today? And their response is immediately about their injury and what they're going through. Now, I never asked about their injury, okay? I just asked how they were doing in general. How's life going? And their first thought, though, is to go to that. And so if you're asking athletes, you're just making conversation, and they bring stuff up like that, it also really tells you where their headspace is at and what they are going through. So that's something to be aware of. Now, what you see build up and where we really start to see issues is the social side, okay? And so isolation begins to happen, where now, and it makes sense, the player's not playing, and so they're gonna get a little bit less coaching time, and they're not gonna talk to the players as much. Now they're rehabbing away from the team. So the whole team's practicing, doing their normal thing, and they're off to the side. This starts this process where now they kind of start to distance themselves and check out. We see an identity loss potentially take place because now, I can't compete as an athlete. This is who I see myself as. And so now they almost start to hide away from the rest of the team, family, and friends. And it kind of develops almost this hermit mentality. And so if you start to see this with athletes and they start kind of distancing themselves, this also, again, tells you what is going on here, okay? And so in this cycle, what you see is if I'm unable to play, there's going to be a combination of shifts of these issues that are going to happen from what normal things they're experiencing to now these issues. But when they're able to play again, okay, now my normal behaviors and my personality return, the smiles return, and everything kind of goes back to normal again. And this is kind of this cycle you see. But I really wanted to reiterate the differences to what athletes are normally going through to then when an injury or a concussion gets thrown into the mix. Now, this next thing that I want to address with you is also related to this mindset of the athlete. And that's to play through injury, okay? If any of you are familiar with the sport world, this is kind of what athletes do, and they're really bred to do this. Well, it's a good question to ask, okay, they play through injuries. Well, why are they doing it? Well, the first motivation is they want to play. This is what athletes do. And so if I just listed all these issues that are going to come from not being able to play, well, they're going to push through certain injuries just because they don't want to have to go through all of those troubles, okay? Now, what this also has led to is a very normalized mindset in sport culture. And the truth is, and if you hear them talk, they're never 100%. They're always playing through something. And so a concussion historically has been grouped like that, okay? And so, yeah, it's something else that I just have to play through. Now, we also have to accept responsibility in society that we also train athletes to think this way because, again, think of the stories we love to tell. Nolan Ryan gets in a fight, guy rushes the mound, bleeding, and yet he's still playing and pitching through it. Hockey players getting their teeth knocked out and they're still smiling and they continue and they don't miss a shift, right? So we celebrate these ideas. We discuss them. We talk about the Michael Jordan sickness game, okay? And so because of that, athletes, it makes sense why they would continue to do this. Now, there's other simple reasons that can take place. Maybe they're just fearful of losing their spot on the team. And they're worried, hey, if I'm not in there, someone else behind me might come along and I may never get my spot back. So I've got to play through this. Or especially peer pressure, right? We know, the most important thing for an athlete is the respect of their teammates and their coaches. And the last thing they want is to be seen as weak. And so this can lead them sometimes to, unfortunately, play through injuries where they're not understanding really the ramifications. Now, where there is some light at the end of the tunnel is this idea of being hurt or injured. And what athletes do is they have an injury and they basically classify it into these two categories. okay? So am I hurt or injured? Well, if I'm hurt, it means I have this injury, but it's not that serious and I'm able to play through it, okay? And again, this is what they're doing all the time, sprains and strains, and my calf's a bit sore, and maybe I'm sick for this day, but I'm gonna continue to play through it. Injuries though, and actually being injured, this is something that again, even athletes will respect. They're not gonna look down on you for, where you tear your ACL, you get a broken leg, you tear your labrum. These are serious injuries. They're gonna take you off of the field, right? And the question is really, where does concussions lie on this scale? I think everybody here today, we would say, oh yeah, well, you're in the injured column, it's a concussion. But historically, again, it's been, again, I shake it off and I keep playing. And I listed a bunch of these reasons why they would do that. So what we need to do is get athletes to put concussions into this injured column and think about it this way. Now, how are we going to get them to do that? Well, the research shows that there's 3 specific things that can be done. So first, a willingness of the athletes to actually self-report, okay? This quote up here, having a concussion and playing through it is not about toughness. That's demonstrating a lack of understanding of the severity of the injury. This quote was taken after Carson Wentz pulled himself from a game because he had a concussion, he didn't feel right. And so now as we hear these stories come out of even professional athletes doing this more, that is going to help. Now, this will also help create social norm changes. So for example, on Twitter, there's an NHL safety mod. What it does is every time there's a concussion play or a headshot that happens in a hockey game, immediately the video gets sent out online to Twitter and everybody talks about it. And you know what this does is it at least creates awareness now of what is going on and how bad concussions are and how often they're happening in some of these sports. And especially what we need to happen is changing these perceptions of the seriousness of the injury, okay? The athlete's thinking about it differently. And obviously my colleagues have touched on some of these ideas and they're going to continue to do that throughout our talk today. But what I want to do is really go through what can also happen and what you can pass along to change these perceptions, okay? So when we have a concussion, we know you're going to see a range of these different symptoms. And again, some of these have already been talked about today, but the physical, the emotional, the cognitive side. But one that gets overlooked and isn't discussed a lot of, and what I'm going to hit on now for the rest of my presentation, is this idea of sleep, okay? And if you notice, sleep-wake disturbances are caused in 13 to 67% of athletes who are experiencing some type of post-concussive symptoms. And so because of that, it's a huge percentage of the population that goes through these problems, okay? So what happens when athletes start losing sleep? Well, what we know from this wonderful resource, which is by Dr. Matthew Walker, it's a book called Why We Sleep. Well, what he's found is faster lactic acid builds up in your system. So your muscles are going to get more tired quickly. Your immune system is going to be down. You're going to increase actually the amount of carbon dioxide that you're taking in, and you're not going to have as much air in your lungs when you're tired. It's going to prevent the sweating process, which is disastrous in an athletic context, okay? And it's even going to give us slower reaction times, which makes sense, right? You know, you don't sleep that well, you're just a little bit slower off the draw, okay? Now, why is this so dangerous, losing sleep, okay? Well, we know athletes who lose sleep and get less than 8 hours are at an automatic 1.7 times chance of getting an injury. And so this, as you see, they start reducing the amount of hours and the chance of injury just goes up and up and up. And so I want you to think about a scenario. So an athlete gets a concussion, right? And they don't say anything. And they're like, yeah, it's probably not that bad. And now they go about a week in a row of, I don't get that much sleep. And they have these sleep issues. And now they suffer another injury. Well, that injury could have been caused because they didn't report the concussion and deal with it. And they're not in their mind going to realize, oh, I just hurt another part of my body simply because I didn't respond to the concussion properly. And what we see is, again, this direct link between sleep loss and injury, okay? And so what is happening here when we're experiencing these concussions? Well, the first thing that we're going to see is what is called a circadian rhythm disturbance, okay? Now, what is a circadian rhythm, okay? Well, every single one of us has this, and we develop it within a couple of days of being born. And it's this biological pacemaker that is operating 24 hours, okay? So what it does is it actually reacts to the sun and the timing of the sun. And what it does is it signals this thing to our brain, which is constantly in operation. And so it creates preferences, first of all, for our body temperature. Now, you may not have known this, but our body temperature goes up and down and fluctuates on a schedule daily. And so if you see kind of in the middle of the night, our body temperature is supposed to go down. It's supposed to get colder, and it does this on purpose. And so if you now have this thrown off and you have these issues where, again, now you're hot and you're sweaty, and we've all been in that situation where we can't sleep, it's going to, again, build on itself. And now this rhythm, our hunger urges are going to be disrupted, metabolism is going to be off, and the chemicals that get released related to sleep, adenosine and melatonin, now they're not going to get released, or they're going to get released at different times than they're supposed to be. So automatically we have this concussion, and we're going to start to see issues related to this circadian rhythm take over, which are really troublesome for an athlete. Now, what develops are sleep disorders because of this. And we know 46% of individuals with TBI develop some kind of disorder. Now, this can be insomnia, sleep apnea, hypersomnia, narcolepsy. These are different types of issues and disorders, but none of them are good. And so we know that a significant amount of these athletes, because again, the circadian rhythm gets disrupted, now start to develop these sleep disorders, which is very, very dangerous. And this is why, because the sleep disorders now are going to create more mood issues. So it's going to even exacerbate the situation, and it's going to create more physical pain in the body because, as I'll explain, our body needs to shut down in order to rehabilitate itself and build up those cells, especially when we are going through an injury. And so TBI is going to prevent and cause this horrific triangle for the athlete. And so what's really happening here, and I want to take a couple of minutes to explain what this is the athlete is going to never get a full night of sleep, okay? Now, how does a normal night of sleep operate, and what is it doing, okay? So just give me a minute to break this down for you, okay? So in a sleep cycle, what we do is we sleep in cycles every single night of approximately 90 minutes, okay? And so what the goal is we're trying to get 5 of these sleep cycles in per night. That's what you're seeing here in this graph right here, is 5 cycles built upon one another. Now, each cycle is approximately 90 minutes. And so when you start to do the math, 90 minutes, 3 hours, 4.5, 6 hours, 7.5 hours, okay? So 7.5 to 8 hours, that is what we're supposed to be getting, because that is the time frame for about 5 cycles to have occurred. So when people say you need to get your 8 hours, this is why they're saying that. Now, within each of these sleep cycles, we go through 5 stages, okay? And this is where the idea of non-REM and REM sleep comes into play. And so this is what you're seeing in this graph. So if you look at, for example, cycle 1, and you look on that left side where it's giving you these 5 stages, and what it's doing is it's telling you the time frame that we are spending in each of those specific stages in that cycle. And so what you start to see is the non-REM cycles dominate earlier in the night in these first 3 cycles, okay? Non-REM sleep is where we're almost in like a coma-like state. We kind of just shut down, our core temperature goes down. And what this is doing is now it's giving the body time to physically rehabilitate itself and get you energy for the next day. Now, as you start going through the night and you start getting into cycle 4 and 5, notice how now this non-REM time starts to go down and the REM sleep starts to go up. And especially in cycle 5, look how much time is spent in REM sleep. Now, REM sleep is very, very crucial for psychological development, okay? And this is known as the rapid eye movement phase, where we kind of spend this time, in almost processing things at an unconscious level. And if you are familiar with these cycles, this is also the time frame that we dream. So the way that a normal night of sleep is supposed to operate is the last cycle, you're going to end up spending way more time in your REM sleep. You're going to be dreaming longer. And typically what will happen is you're going to wake up from a dream. And that's how most nights of sleep are supposed to be. And that's why you wake up, you know, it's like, oh my gosh, okay, my heart's beating, I was in this dream. And it's because you were coming out of this REM sleep. And so the last cycle gives us most of our REM sleep of the night. Now, the problem is when we start to lose hours of sleep, most of the time we're giving away this fourth and fifth cycles. Someone has a concussion, they're automatically going to be losing these cycles. So physically, maybe the body is recovering at night through the non-REM sleep, but we are not getting the REM sleep. And this is, again, where this is disastrous psychologically for somebody, because what starts to occur is we develop psychiatric symptoms now, okay? And so anxiety, depression, ADHD, and even PTSD can develop simply from a concussion that is, again, playing out for a long period of time. And now we're losing these sleep cycles. And so if any of you have been in this, you know, a situation where it's like, I'm not sleeping much, and week and week and week, and just builds on one another, right? And you're never getting that last couple hours, you start to think that that's normal. And yet you start to get edgier and more emotional, and you're not necessarily putting the pieces together that because I'm losing this last section of sleep that I need, now it's going to create this litany of issues going forward, okay? And so what we see with these athletes, fortunately, in the short term, a majority of these symptoms are going to resolve themselves over a couple weeks, okay? But the long-term ones, and some of what my colleagues were discussing, is 10 to 15 are going to have prolonged symptoms. They're going to have issues falling asleep. And when they do fall asleep, shorter duration. They're going to wake up more during the night. If they already have ADHD, the symptoms are going to be even worse. And what can really start to occur is we start to go and medicate ourselves. Obviously, this is a big issue in our society too. And so now the body is getting medication. And so when we're talking about releasing those, you know, chemicals that we need to sleep, well, now it's going to cover up for that. And it's just going to, again, make this situation worse and worse. And it's going to steamroll on one another. So how I wanted to kind of conclude what we talk about here is give you a few recommendations that I think can help no matter what role that you have, okay? So number one, tracking our sleep patterns. You can do this on basically every phone now today. And there are so many different applications out there where you can track how many hours you're getting and even your sleep cycles at night. And so you can start recording that information and you can really see, okay, how much am I getting here? And am I seeing these issues and disruptions going on? Number two, these social check-ins, kind of monitoring the progress of the athlete. And what I mean by this is I don't necessarily go up and, hey, how's, you know, your concussion protocol going? That's not what I'm talking about here. And that's not something most of us should be discussing outside of the trainers. But what I'm saying is, how are you just doing in life? Making them feel connected, and that just because they may not be playing sport, well, they're still important, and really cementing that identity as the human side. Those things are going to be very crucial to do with these athletes that we notice start to kind of drift off and isolate themselves. And so then this last thing that I would recommend, and this is something I talk a lot about in class too and work with athletes on, is breathing as a skill. And obviously everybody's breathing today, so we don't necessarily think about it as a skill-based idea. But there's a couple things that if you start focusing on breathing, especially if you're an athlete with concussions, that can help, okay? So number one is your posture, just normal. So even while you're sitting here listening to this, have you been sitting hunched over? Are you sitting directly straight up? Well, why is this important? Well, in normal breathing, we need the air to get all the way down into the diaphragm, as you can kind of see in this photo. And this is how it's supposed to work. And what we know, athletes who have concussions or injuries, their body language is going to be poor. And so what's going to happen? They're going to be more hunched over like this. Now, what this does is it's going to stop the air from getting into the diaphragm. And what it does is it turns on our stress response in the body. And you don't feel it happening. And so you're still breathing, but the stress response just stays on. And so it's this constant state of anxiety where why am I feeling this way? And a lot of it is just bad posture. And so needing to kind of sit up more and allow the air to get down there. And now the second piece that you can do with breathing is being able to just take a deep breath, because we know they're going to be stressed and anxious and they're going to need to just be able to calm themselves down from time to time, right? This is just a useful skill in general. So being able to just, you can control this, you're going to work through this, and let's do it. Something as simple as that can be very, very effective for an athlete who's going through this and who is just kind of stressed more than they're accustomed to, okay? So if you can start, implementing a few of these recommendations, I think this can be very, very helpful going forward for some of these athletes that are sustaining concussions, okay? So again, the goal for all of us here is player safety. And the thing is, we want to educate athletes about the facts, what's really going on here. And then that can help create these perception changes within the athlete. And again, it's going to be on all of us to be able to do this in all of our different roles. So again, I want to thank you for your time today. Really appreciate this. Go CSUN definitely. And if you need anything at all, you want to reach out to me, there's my information. But I'm going to pass it back now to Felicia, who's going to pass it along to our next colleague.
Okay. Got it. Go CSUN. Okay, right. I'm going to do a fast pass to Jillian so she can get us started. Ready, Jillian? Here you go.
Thank you.
Nice catch.
Dr. Conlan. All right, so our next speaker is Dr. Lisa D'Angelo. Dr. D'Angelo has been a practicing speech-language pathologist for 33 years in schools, hospitals, and universities. An assistant professor at California State University, Sacramento, she teaches and mentors students in neurological development, disorders, assessment, treatment, and research. She also works in acute care for Mercy General Hospital and is a consultant for 2 school districts. Her research, publication, and presentations focus on cognitive communication deficits after TBI and concussion, neuroplasticity, and dysphagia. All right. Are you ready, Dr. D'Angelo?
Good throw. All right. Good afternoon, I guess, everybody. I am Lisa D'Angelo, Dr. Lisa D'Angelo, and I will bring up my information here. Let's see here. There we go. So I am here to talk a little bit about what do we do about the people that have persistent issues. I kind of fell into this. I am from Sacramento State, as you can tell. A lot of my students are here, my colleagues. I'm very excited about that. I am a speech pathologist primarily, and then I also did my research that really focused on brain injuries during my PhD. So these are just some of the objectives of what we're going to talk about today in my presentation, and it does really connect with all the presentations you've heard earlier as well. We're going to talk a little bit about the concussion overall, neuroplasticity, what that means, assessment, treatment, and some case studies. And I kind of fell into this. I've been a speech pathologist for a long time, and I've always worked in the hospital throughout my career primarily with people with neurological disorders and injuries. But I also really became very interested in concussion after being a mom with 2 children who are lacrosse players, one who is currently playing lacrosse for UCLA, and another child who was big in baseball. So this was not something that was out of my range as a mother, but it was something that didn't really occur to me as being something very concerning or a big deal. And even though I had worked with brain injuries my entire career, until I talked to another parent on one of my son's teams who was a nurse for a large hospital in this area, and her daughter had a full ride scholarship to USC for soccer. And her daughter was amazing, super smart, just very, super high achieving. And she had her 3rd concussion in high school and was never able to continue on her path. She was never able to continue down that road that she had plotted out. So that was eye-opening to me. And that kind of started me in the research in this area. Also, my own son, like I said, is playing lacrosse right now for college. And he has had his first concussion 3 weeks ago. So I got to see firsthand the response from his team, the athletic trainers. His teammates were wonderful, all watching out for him, just very, I was really impressed. And the athletic trainers and the coaches, very just on target with what we're talking about today. So that was really great to see. And I hope we can keep moving forward in the world in this way. As was mentioned earlier, and some of this is going to be redundant, the issue with concussion or mild TBI, persistent cognitive concussion syndrome, whatever you want to call it, there's so many different names, is that there's the possibility of diffuse axonal injury, which means literally that axons, connections in the brain, are being torn. And if axons are being torn, neurons on both ends will die because the disconnection actually creates a secondary death. So there's an initial as Dr. Conlan mentioned earlier, it is not usually in one area. It can actually be large amounts of areas throughout the brain. My internet connection is unstable. I don't know how it knows that I'm unstable, but hopefully it'll be still connected. So this is the concern, is it is a widespread injury. Neurologically, and Lisa is going to talk about this later about radiology and neuroimaging, we can see some things. We can see MRIs, maybe we can see concussions later, but we really can't see them we can't see them at all on CT scan. So that's just a wash. And that's of course the first thing they do in the ER is they do a CT scan. On MRIs, you can see up here in the right-hand corner that there's some little white dots. Those are actually previous concussions. You can see kind of on the bottom, there's some more injury delineation in those MRI images. You can also see on the left, and this is MRI, this is actually activation studies on brain, functional MRI, looking at activation patterns in the brain. And on the left, you can see without concussion and after concussion for both working memory, which is holding things in your brain briefly and then doing something with it, and motor planning. You can see that the brain before concussion is actually not as activated as after, but that is not meaning that it's better. It means that it's more disorganized. And in fact, a lot of the brain is trying to help. It's trying to figure out what's going on. So it's almost like an overactivity, an over response. So the symptoms that we see. We've talked about all these symptoms several times today, so I won't really go into these, but these are some of the things that people continue to talk to me about. And what the people that I'm talking to generally are the people that did not heal after 3 to 4 weeks. So I have a large portion of people that are contacting me every week who have had a concussion, and it's definitely more than 4 weeks ago. And sometimes it's months, sometimes it's years, and they have persistent symptoms. So sometimes it's called persistent concussion symptoms, persistent concussion syndrome, whatever it is, it's a mild TBI that has persisted. So they complain of many of these symptoms. And one of the ones that is most concerning for life is cognitive communication changes. All of these are concerning, but cognitive communication, being able to pay attention and remember things, is very impactful on work and school, etc. So past to present, we used to say, go into a dark room and don't use your computer, don't use your phone, and stay there until you feel better. And that really wasn't that long ago. Now, research around 2011 was when the first recommendations came out in research that said, hey, it's better to have a gradual return to physical and cognitive activity. And that should start after about 24 to 72 hours. And you should have accommodations for return to school, return to work. It's very gradual. In fact, I was on my son. My son was afraid to call me after that concussion, but because he knew exactly what I was going to ask about. But all those things occurred, thankfully. There are return to play recommendations now, of course, and those have been pretty widely adopted, but still can be more followed more in depth. Return to learn is a policy that has not been widely adopted, and we are working on that. I did answer several questions about it in the Q&A. That is something that is needed, and we need more consistent follow through when we do have it. And then what I really want to point out is that 70 to 90% of people who have concussions or mild TBI recover completely in 3 to 4 weeks, but some do not. And if you think 70 to 90%, that means 10 to 30% do not. And that's a pretty big number if you think of how many concussions occur. So the issues with diagnosis are that, number one, people usually look pretty good. That is a real book. That's an article that was posted, and there was a book that was also published called You Look Great. And people with a concussion, sometimes they don't look like anything happened to them. They look the same. They're not always seen in ER. They may not have lost consciousness. It will not show up on the CT scan, so that's almost a waste of time. Anxiety and depression can be a result, but not necessarily the main diagnosis. A lot of people get misdiagnosed or get prescribed medications for psychiatric issues because they are having anxiety and depression, which may have been there before, but now it's because of this brain injury also. and the experience and the symptoms that they're feeling. There is a disconnect between research and current knowledge. That's always been the case. Research is always about 10 years ahead of public awareness. So that's one of the reasons why we're doing this presentation, is to really continue to get the word out. And the military and the VA, that was a big area. I did my some of my work in my early career at the VA in Menlo Park and Palo Alto in the brain injury rehab unit. But at the time, the military and the VA were not really addressing concussions, blast injuries were kind of not even on the radar at that time. And now the military and the VA is doing some really great research and have really great approaches to dealing with it, assessment and treatment wise, for their people in the military. So also, what about kids, teenagers, children? That's a big thing, right? We used to think, oh, their brain is still developing. It's no big deal. They can still make new connections. Their brain is still figuring everything out. They'll heal better. That's what we used to think. Well, that's not true. Unfortunately, anytime you have an injury to the brain, it is potentially interrupting brain development. So that's a concern. And a lot of times children have injuries early in life before school, and those issues don't show up until later when we actually put them in academic rigor and they have to use those skills, and that becomes an issue. They might have behavioral issues, learning issues, attention issues, all kinds of things that can show up in school. School-age concussions, of course, the same issues exist. Identification, diagnosis. There are very disorganized approaches in the schools. There are a lot of people who are willing to help, who want to help, athletic trainers, school nurses, primary care doctors, parents, teachers, coaches. Everybody wants to help the child or the teenager. However, it's very disorganized. And sometimes people are dealing with it who don't really understand about brain injuries. And sometimes they have different, background or different thoughts about what should happen. So we really need more consistent use of return to learn. There is a lot of pressure to return to school, being a mother of children, a child who is in college now, there's a huge amount of pressure on grades and sports. And what about a scholarship for getting into school and for getting to play for a team? So that is a big amount of pressure, and also trying to get back there as fast as possible, right? You don't want to miss school. You don't want to miss the team. You don't want to lose your spot. It is a developing brain. We do know that long-term effects, especially if there's multiple concussions, we don't know how many is too many, unfortunately. I've had people who had 11 concussions, and the 11th was the one that tipped them over the edge. I've also had people with one concussion, then that has been the one that's persistent. So we need more addressing of these issues long-term, and also more consistent addressing of these issues. Other states do have these programs. We are working on it in California. CASHA is now working on this with us. We have been trying to get this through with the Department of Ed and the Special Department of California as well for special education, but we're still working on this. It's still an ongoing process. Now, one of the great pieces of information that I really made me very happy when I learned about this years ago is neuroplasticity. And this is kind of the good news. The good news is our brain has the ability to learn throughout life. Your brain is primed for learning. It doesn't matter how old you are. You can still learn. And in fact, if you continue to learn throughout your life, you are more likely to make more connections to offset or prevent dementia. So that's one thing. The other piece of that is that throughout life, we have the ability to learn whether we're being habilitated in developmental processes or rehabilitated. Your brain has the ability to make new connections. Your brain can have the ability to create new neurons. There is something called neurogenesis in certain regions of the brain where new neurons can be produced. Also, more importantly, is that with all these neurons that we have, and some of them we don't use, we have the ability to make new connections throughout our life. And that is what therapy is about. That's what teaching is about. That's what therapy is about. You need those abilities to make new connections. You need to be able to learn. You need to practice those connections. And the things that are not used are going to be lost, but the ones that are used and practiced will be learned. So this is another visual of that. The brain, this is neuroplasticity theory. The brain is primed for learning. The experience must be specific. It's dependent on experience. So you can't just learn by being in a room and just kind of sitting there. You have to learn specifically what you're working on. You make new connections with that. Those connections are reinforced through practice and learning, and then we reinforce that, and then you go on to learn at the next level. So very hierarchical and also very connected. It's a continuous circle. Now, this makes me really happy too. I get really excited about these things. My students think I'm crazy. But this is evidence of working after therapy, the areas of the brain that showed improvement, that showed neuroplasticity, structural neuroplasticity changes with neuroimaging. This is DTI, which is probably the better kind of neuroimaging, and Lisa's going to talk about that more later, for brain injuries, because it can show very small injuries, and it can also show improvement over after therapy, which is why I love it. For the picture A, that is actually the corpus callosum. That shows neuroplastic changes after therapy. B is showing the based, as well as D is the cerebellum. All of those areas have to do with learning and language. So that is very exciting. So current research, I'm not going to go deeply into these things, but just know that there is current research that shows that there is ability to improve after having cognitive issues after a persistent concussion diagnosis. So and this one is in the military, I believe, and they compared having just a medical approach or having a therapist work with somebody on cognitive rehab or a social emotional approach. All of the patients improved. However, those that had just psychoeducation alone or medical management alone did not improve as much. Also, another study also was looking at, I believe this also looked at military people as well. They compared cognitive computer rehabilitation with therapist-driven cognitive rehabilitation and cognitive rehabilitation in general. CBT, which is cognitive behavioral therapy, psychoeducation, they noticed that all of the people improved. However, cognitive computer rehabilitation by itself was not as effective. In fact, it was negatively associated. It actually made worse symptoms. And then another study also showed comparing usual care versus an enhanced care with therapy, vestibular therapy, cognitive therapy, vision therapy. All of those patients improved dramatically more than not having that extra therapy. So, and there's another study here that looked at PTSD, depression, and sleep. All of the improvements were seen and in symptoms as well as their own self-reported cognitive skills. So this is Brain Steps. This exists in those other states. We're trying to get something like this in California. And this is actually an oversight organization that goes out and teaches teams in every school district and every school on how to deal with and how to support a child or teen and their family and the staff working with that student. So all the specialists, these are all the people that could be involved. It's not just the speech pathologist. We all work together medically for, you can have headaches and sleep issues that are dealt with medically. Physical therapists can work on balance and vestibular issues. An athletic trainer can be the overseer of the entire system. Occupational therapists and neuro-ophthalmologists can work with vision issues. School educational psychologist, a psychologist, counselor, or social worker, of course, the speech language pathologist, and teachers. We all need to work together to support the students and the children in this process. Now, Nancy already talked to, Dr. Cohick already talked about our role, education, prevention, assessment, and I'm going to talk more about treatment as well. Our scope of practice, as Dr. Cohick went over, involves all of these areas, as well as specifically naming mild head injury and concussion. We can do assessment. We can do assessment with questionnaires, self-rating scales, standardized tests. We can use neuropsychological tests that look specifically for the areas that are a concern. And we also do motivational interviewing, figuring out what is going on with the patient. What areas did they identify as issues? The patterns of deficits usually look like impaired attention, sustained attention, selective attention with noise or distractions, being able to alternate attention between tasks, doing two things at once or more. Impaired working memory, which is that holding something in your mind and doing something with it, which we use all day long. Delayed memory for new information. Executive functions, all about organization and planning that Dr. Conlan talked about. Some social language issues because of the attention and memory. Word retrieval, people experience difficulty with coming up with words, and reading comprehension, which is interesting because it's really more of an attention issue, a vision issue, and a memory issue with reading. So treatment, in all the treatment that we do with brain injuries, these are the same principles, and it's just at a higher level a lot of times with mild TBI versus severe TBI. So we do stimulation, we work on attention, working memory, all of those areas, deductive reasoning, executive functions, and working with noise and distractions, and we work in a hierarchical way. We can work on compensation, using memory strategies, using different kinds of assistive technology. Education and training. Education is and knowledge are power. If you understand what you're working on or what's going on, you can make a difference in it. You can change it. We do a lot of therapeutic counseling. And of course, we work on the context of what they need. If they're a student, I'm going to work with them on remembering things for tests or studying. If there's somebody who's going back to work, I'm going to work on their skills that they need for their work environment. So this is an example of one of the people I've been working with in my research study recently. I have a research study that's ongoing. That's an RCT looking at cognitive communication rehabilitation for mild TBI. This person was is a mom, and she was T-boned by a semi, and she had no loss of consciousness. She was a police person who set, what's the word for a police? She was the person who set people out on calls. So she had to be really fast in her thought processes and making a lot of decisions quickly. She was part of my study. This is pre versus post results. This is raw scores, but you can see dramatic improvement in just 8 sessions of therapy. She was able to go back to productive work after doing this study. This is an example, another case study. This is a woman who had a very successful career, college graduate, very intelligent. She had a car accident, didn't even know she had a TBI. She went home, didn't even go to the ER, nothing. She had terrible headaches. She was diagnosed as having psychiatric problems. She came to see me when I was doing my initial research, and she literally got up and walked out the door when I started testing her because it was so painful. She came back years later wearing dark glasses and earbuds and a hat, and spent the rest of the time working with me throughout the research project. And she has gone back to college now, and she is learning to do a different career because she has improved enough that she can go back to that process. Another gentleman I worked with was retired. I do have a lot of examples of students too, but these are some examples that are of other people that are a little bit older. This gentleman just tripped. He tripped at the Little League game as a scorekeeper. And hit his head, went to the ER, told to go home and rest. He couldn't go back to work. He really struggled. He had visual issues. He still wears kind of prism glasses. He found my research through a support group, and we worked intensely for 8 sessions, and he was able to go back to work. And he's actually back now working with some of my students because he wants to keep getting better. And so that's my information. I'm happy to talk to anybody afterwards, and you can contact me at this email. I'm very appreciative of being part of this team. This is an excellent opportunity to get the word out, but also to really hopefully educate, and hopefully you guys can all go out and educate everybody about the knowledge that you gained today relating to mild TBI and concussions, the invisible injury. So thank you very much.
Thank you so much, Dr. D'Angelo. Lots and lots of information we're imparting today. Thank you. Okay, we're going to do some more interactions here. Oh, I got you. Thanks, Lisa. We're going to do a quick survey. Okay, let's put that up. More of the myths that we hear. You can make new brain connections throughout your life, no matter your age. True or false? And the second one is concussions only occur from directly hitting your head. True or false? Okay. Let's see how well our audience is doing. Okay, true, exactly. So the first one is true, and the second one is false. You guys are awesome. Okay, so we're going to do a quick turnaround. Our next speaker is someone we are very, very excited about. If you need to take a stretch break, please take your stretch break. If you need to get some water, please get some water. We are going to plow ahead and go on to our next speaker, who is actually doing some exercises as well. Maybe I should just mirror what you're doing. Okay, I am so excited and proud to share with you our next speaker, Dr. Eric Sletten, who has served as the head team physician at CSUN for over 30 years and is the coordinator of the sports medicine clinic at the Klotz Student Health Center. He was an emergency room doctor for 20 years and is board certified in family and sports medicine. He has a private practice called Sletten Wellness Medical Center in Ventura, California. Okay, take it away, Dr. Sletten. You ready? Here we go. Oh, uh-oh.
Okay, whoa. Let's see. Thanks. What was your name again? Felicia. I'll introduce myself. My name is Seth Curry, and I'm a professional Wordle player. If you haven't done your Wordle today, I probably beat you. Okay, that's an example of a stinger. No, not a stinger. I just got my bell rung. So we're going to take away that definition of head injury and jump into my talk. Welcome, everybody. Let me share my screen. Okay, can you see that? Move people over. Okay. Once again, my name is Eric Sletten, and I've been the team physician here at CSUN for a long, long time. Welcome all the alumni. I'm a local kid. I am not in the CSUN alumnus, but I grew up right down the street. I was born at Northridge Hospital, went to Northridge Junior High. I played basketball for the Northridge Knights, and my older brother and sister graduated from CSUN. I got out of the Valley, went to UC Irvine for undergraduate, UC San Francisco for medical school, back to Ventura Medical Center for family practice residency and fellowship connected to UCLA in sports medicine. So I'm double boarded, and that's what a sports medicine physician is these days. It's someone who's boarded in some form of primary care and then has done a year of fellowship training. You have to take tests to pass that. And of course, there's dues. So let's talk about the brain. And these have been some amazing talks this morning, and I'm so appreciative of everybody here. I'm going to try and put a few more tidbits in there that are just my brain speaking to your brain about this problem. So I put this picture up. Central nervous system consists of brain, spinal cord, peripheral nerves. I left out the mesenteric nervous system, the second brain. That's another lecture. The rest of us is just sort of binding integument. And my daughter gave me this idea. She says, she was studying this in her high school class, and she said, maybe we are the aliens, and maybe we've just been watching a little too much Stranger Things. But really, it is really what drives us is our nervous system and coordination. And remember, we're brain is an organ, and it's an organ in a box. And you've seen all the definitions of how you can injure that organ. This organ does have a special status, though. It has its own sort of circulation. There's something called the blood-brain barrier. Everything doesn't get into your brain area. That's really good news for us for all the horrible things we put into ourselves sometimes. And also it has its own sort of immune system, and it's very interesting. But it's very important to remember that it's a complex circuitry, and it's an electro sort of chemical connection. And we'll come back to what can go wrong in those areas when we think about brain injury. So there's a common slide. You've seen it, and you're all experts now. So what I'd like to talk about a little bit is let you pick my brain to what I'm thinking of when I'm covering an event and when I can let someone go back into play. What goes into sort of that decision after the concussion has happened in my office, and then what goes into the decision of clearing someone to play. And I'm going to share with you a lot of nice little pictures of some of the imaging and some tests that we're trying to sort of explore to help us with this really hard decision. And when you think about, doing ER, and like I said, I'm a family doctor. I did ER for 20 years. I sort of got out of that business so I could kind of sleep in my own bed at night. It's been really great. But the biggest question we answer, in the ER is are you going to be okay? Are you okay to leave? And that's the decision you make 30, 40 times a shift, and people come in and they just want to know that they're okay. And we'll talk about what we do there from an ER standpoint, from the field management to the ER, and then on to sort of long-term evaluation. So a lot of this information comes from a lot of really concerted efforts from a lot of experts trying to put some sort of an evidence-based expert consensus together. And what we have, and this is basically Zurich is where they met, so they call it, when we refer to Zurich meetings, which has been updated over the years, It just happened to happen in Zurich, which is a nice place to go. I didn't get invited, but that is where most of this information comes, and it is a best practices summary. So even though we have all these laws in states for seeing a physician when someone has had a brain injury, there's no actual standard of how we go about evaluating that person. So there's a huge spectrum of experience and knowledge of how we make that decision of having someone go back. And when we say you can go, that's the biggest decision, right? Just saying they're okay to play. So let's move on and see how we can make that decision. Well, back in 2014, starting to be a long time ago, the NCAA and the Department of Defense put together about a $30 million effort, a 3-year study to really look at concussion. And this has been ongoing. These sorts of studies have been ongoing for a long time. And it's some of the results are extensive, but I'm just going to show you one, and I'll tell you why I think it's important. In this particular part of the study, response-wise, NCAA study in 1999 to 2000 had 184 concussions. They looked at a 3-day recovery, and they compared that to the CARE Consortium, which was part of this newer study, inviting people or subjects into this concussion evaluation study. And they looked at more than 12 days of symptom to the time of symptom-free and waiting period. It's longer, and I can't tell you exactly the last time I used 12 days as the time that I told athletes that they can go back, that they did in this particular aspect of it. And they claim to have decreased the risk of repeat concussion by about 41%, just by waiting. But also it's all these other things that you've been hearing about from our presenters, all these ways into the lives of these young people who have sustained this injury. And I think this made a big difference. Why do I think that repeat concussion is important? I think it's because I think that your brain does count concussions. And through all the literature, you will not find a number of concussions after which you shouldn't play collision sports. It just doesn't exist. Just as was just shared by Lisa, there is no number out there. But however, when you come in and get a physical exam in my clinic, one of the questions is, how many concussions have you had? And I think that's a good number for the athlete to sort of mentally, or an exercise for the athlete to go through and say, wow, I had one this year, and then I had one this year, and then I had one this year. And those are the ones that they remember, right? And there's also ones that they may not remember. So when they get a concussion, we actually add to that number, concussions times fill in the blank. And I'm going to tell you right now, when people start getting up to 4 or 5 concussions, I'm starting to watch that person, and I'm starting to ask them, from a cognitive standpoint, how are you doing? They might not have any headaches. They might not have anything at all. There might be some subtle things that are getting into their processing. And I think that's really important. And sometimes things are so subtle from an emotional interrelationship status that it's worthwhile sort of exploring for that athlete. So I do count concussions. I don't know if everybody does, but I do. So before I move on, I'm going to tell you a story, because people who know me know that I like to tell stories. So this is a story of me, actually, and so I don't have to worry about HIPAA violations. This is a Northridge story, though, because I'm a Northridge kid, and it was 1974. I got this bicycle, and I think it's some swap meet. I found one of those cool speedometers, and I was riding on President's Day on a bike ride with my sister, and we were exploring the very top of Reseda Boulevard. For those of you who know Northridge, and all those houses were just being built. It was all this new construction. And I started screaming down that hill, and the last thing I remember was 35 miles an hour on that silly little, speedometer they'd hook up to your front hub. And I just remember rolling and rolling and rolling. And this is how we treated concussion. I got up, there was some guy driving by. I had memory of this quite clear, even though I was a little kid. Lincoln LTD, remember that? And threw my bike in his trunk, brought me home. And my parents promptly put me to bed. And They looked at me. I was literally throwing up, coming in and out of consciousness. Time was sort of perception of time was really gone. These are things that I remember. And I don't know if anybody else remembers because I'm the youngest of 4 kids, and I think everybody just sort of went on with their Saturday. But bottom line is, I had a real concussion that today, most parents would bring that kid into the ER and to get a scan. And so, or to get checked out. And the reason I say that is because some people have expectations of getting a scan or some form of imaging that's gonna confirm that the child is okay. And we'll talk about whether that's a good idea or not. No helmet, by the way. So concussion now, and like I said, there's CAT scan, MRI, but Lisa's going to show some amazing pictures of CAT scans and MRIs. And I'll just say, just as a quick caveat about going to the ER to get a scan, there was a time when CAT scans became very easy to do from the ER, and ER doctors were just knee-jerking CAT scans for any kid that came in with a head injury. And what they realized that the children who were getting these CAT scans were also getting lymphomas later on in life. And they realized that this is a significant radiation exposure, and we stopped doing it unless they really needed it, right? So when I examined and did a careful exam of a child in the ER post head injury, if that exam is non-focal, meaning there's nothing that jumps out at me, and they're having basic concussion symptoms and a few signs, I reassure the patient and the parents, and I let them know that I don't think it's a good idea to CAT scan your child. I think we should just watch them carefully tonight. And they say, but I want to scan. And then I tell them the data about cancer, and it's really easy to talk them out of it. But there's still some ER doctors even today who would just do the scan because they don't want to miss something. But what you'll see is that these studies, CAT scans and MRIs, tend to be very normal in classic concussion, and that's pretty well known. But let's talk about some of these odd scans. I don't mean PET scans like FIDO. I mean positron emission tomography, and this is really interesting in looking at chronic traumatic encephalopathy, which is sort of a subset of potential long-term effects of some repetitive brain injury. And what you see here is a PET scan is kind of a measurement of metabolism. There's different types of tracers. Some of those PET scans reveal sort of glucose metabolism. In this particular scan, it reveals the concentration of this neuroprotein called the tau protein. And you've all heard about this in some of your brain science classes as to be sort of possibly a marker for Alzheimer's disease. And so what you see on the right side of the screen is a typical PET scan of Alzheimer's disease, and it's the concentration of these tau proteins. And they tend to start interior and they move externally, more peripheral as the disease gets worse. The control over here is they don't light up at all. And in the middle is this chronic traumatic brain injury, and that's a little frightening because we don't want to lose our mind because of these concussions. And I will say, we don't know what the long-term effects are. Obviously, there's lots of long-term sort of prospective studies going on with NFL athletes, people who have had some a wide spectrum of symptoms. We think secondary, to the either low-grade or sort of event-driven sort of head injury. But the bottom line is we don't know how every individual brain is going to respond. We just don't. This is a tough time for me, but I just lost my cousin last week. He was the same age as me, great athlete, and he played football in high school and a couple years in college. And he became an engineer, smart guy. In his late 40s, started getting seizures, and he and his neurologist couldn't figure out why this was happening. Very hard to control. He and his neurologist thought it might be from those concussions that you had, and he finally played at UC Davis football and got out of it just because he was getting so many injuries. And so he ended up having an intractable seizure disorder and actually passed away last month. So is it to prove this? It's really hard, and you're going to hear, from David Bobrosky, and an attorney, and you'll see how hard it is to tie these old injuries to chronic disease. But some of these images might help us in time. Do we do these things on a regular basis? Not yet. So what about SPECT scan? And you might have heard of that. It's called the single photon emission computed tomography. And this is a measurement of flow and blood flow specifically. And what you'll see here in this left side is the usual negative CT scan in a concussion, the usual negative MRI in a concussion. What you'll see is an area in the parietal and the frontal lobe that has low blood flow. And the question is, in an acute setting, you might be able to see that. Is it recoverable? I hope so. But what you'll see over here is kind of a 3D SPECT scan. And if you've ever heard of the Amen clinics, he does a lot of SPECT scans in his practice. And then what he was demonstrating was a 14-year-old after 2 concussions. And there's just less blood flow out to the periphery in this particular SPECT scan. So that's a little ominous. And of course, the question is, would you let your child play football? And man, after the concussion movie and that whole long article in Sports Illustrated a number of years ago, there's a lot of parents that are asking that question: is it worth it? And another thing that we're starting to do is maybe do a better job of looking at the eyes, and in oculovestibular testing. I do part of, an eye exam is part of this. They say that, the eyes are the window to the soul, but they're also a window to the brain and how irritable the brain is and what's going on, because it really is, you're looking at an actual nerve coming out to the surface when you're examining a retina and watching how eyes respond. And so, like I said, I do that as part of my exam. I'm going to say pridefully, very proud of our CSUN physical therapy department. Doctors Peggy Roller and Amy Kachinwe are professors, and we're actually just started a concussion study this year. We actually started it right before the pandemic, and kids stopped banging their heads and they stopped exercising and they stopped doing lots of things. They stopped getting injured. So we just started again, and now that the pandemic is and the university is opening up, a 3-year study to look at very specific dynamic vision tests by experts, physical therapy experts, and I sort of offered myself as the control, because I'm going to be the primary examiner of all the people who get the concussions, and they're going to have me do what I do, and then they're going to see if some of these baseline vestibulocular tests have changed or have recovered. And I'm sort of exposing myself, but I've been doing this a long time, and so far so good, I think. But that's a study that's happening right here at CSUN. And some people say, "Hey, Doc, what about that blood test? For concussion?" And actually, there is a blood test, a couple of them. They're actually FDA approved, and these are called the brain trauma indicators. And what these two enzymes do is sort of leak out into the blood supply when some of the neural elements are injured. It's kind of similar to a troponin when you come in with a heart attack or you're having chest pain, and this troponin leaks out, and we measure it, and it tells us whether your myocardium is being stressed out. This is kind of a similar thing, and so this is pretty recent. Are we doing it in the ER? Not yet, but it is approved by the FDA, and I think it might help, especially the ER physician to just once again say that you're okay when you leave the ER. And what you see early is that these markers tend to elevate early. The GFAP is about 2 hours. Peaks out about 20 hours, so it's still useful. Then it comes down after a couple of days. Same thing for the UCH. Peaks a little bit earlier, but it does come down within a number of hours to baseline. So it's quicker, but it does, if those are elevated, it'll give us a cause to sort of pause and take the person out. It's sort of ammo for sort of getting somebody into a concussion program, maybe even if they feel okay. But we'll see how the data sort of falls out over time, whether these blood tests become useful. You know, I've been in this business for a long time, and all these tests are just data. My sort of allegiance and dedication is to that one patient in my office, one person at a time. And so these are just sort of tools for me to offer the athlete to let them know that they're okay. Like I can say this test is good. That's good news, right? And sometimes they need that emotional kick of confidence to say that they can move forward, even though they might be having some symptoms, right? So we'll talk more about that. And our other providers or other presenters here have done a great job of talking about moving into that space of low-grade symptoms and becoming more active, the return to learn, some of the exercise that you can do while you're still having symptoms, and that's pretty new. And then lastly, brain mapping, and this is an EEG basically. So we're taking on the changing effects of the electrical signals purely, and what we've looked at is trying to inject neurofeedback into brain recovery. And I won't go into specifics of this, exactly what neurofeedback does, but it does imply sessions looking at a screen and actually retraining your brain at different wavelengths. And what you see here on these on this side is alpha waves, beta 1, beta 2, delta and theta waves, gamma and theta waves. And what we see before the neurofeedback is what's good is white areas up in these two areas. And that means that's a balanced electrical response. If it's red, it's high level response. If it's blue, it's low level response. So it's a measure of sort of density of electrical activity. And these views down here, it's kind of a measure of jumbled electrical activity. It's not necessarily connectivity. The thicker the lines between those areas is actually not a good sign. So after some neurofeedback, some of these neural connections have been balanced out and are much more functional. So I'll just share real quick. Shout out to Brian at Brain Performance in Westlake Village. Once again, HIPAA reveals that this is me. So I got to do this myself. I was, testing my family, got kind of a package deal, and I said, I'll just see. And it looks like I was pretty well balanced in alpha waveforms. That's basically how well you are calming. I was a little underactive in some of the theta and the delta waveforms, which are more slow waves, and then I was pretty well balanced in these beta, high beta, beta 1, beta 2, and so no big deal there. But there are some areas of interest in this area, the red over here. What you can see here in this tracing again, there's some jumbled areas here and here, and what the operator told me was that there's elements, and I didn't say one word about myself when I did this test. He says, these are probably old concussions. And I thought, wow, well, you guys know about one of my concussions, but there's two others that are sports related that were pretty significant. Loss of consciousness is one, and both just in contact sport basketball. So that's very interesting. So what that says is there's recoverability in the brain. I hope I'm doing okay, but now I can say every time I'm not behaving right in my house, it's because of these old concussions. But the reality is there's probably a bit of a scar phenomenon that goes on electrically in the brain that like Lisa was saying before, you can recover from. These are some of the most common sports. There's men's wrestling is #1. Whoever got that was correct. I'll move on to the difference between, the difference between collision and non-collision sports. You all know pretty much how to diagnose concussions. And what I want to say about acute care is this. High school football is the most terrifying thing to cover for a physician, or at least it should be when I talk to residents and my fellow about going in the community and just showing up at a football game, high school, because what you're dealing with is minors. Parents may or may not be there, and you're in charge of the visiting team as well. And so, our attorney, David, can attest to what a medical legal nightmare this could be for you, just to do a good thing in your community. But there's all these different levels of physical maturation, which is also a reality in high school sports on a lot of levels. So frightening. So whenever I did this, I'm happy I don't have to do it anymore, but I would always get their phone number. I would call the parent if they weren't there, and I would check on them later on to make sure they're okay. In the heat of the moment, we have to do a quick exam, and the nuances of that I won't go into detail, but it does involve some visual testing, some cognitive testing, some balance testing. I'm not sure what this guy is saying to him. I think he might be saying, look, son, I think you should try out for maybe long distance or cross country. That's a joke to an old movie, but every physician has their own way to assess quickly to know if someone should return. And in football, we can just hold the helmet, and that's what we do. Soccer, it's tough, and a lot of times soccer athletes can sneak back in, even though you're not finished evaluating them. I give everybody at least 5 to 10 minutes to recover and test them again. In our office, there is the standard assessment of concussion. These are all variations that we can do on the field. This can be done in the office as well. All physicians should have some variation of this. Obviously, the sports concussion assessment tool, SCAT, is more extensive, but also very effective. There's the balanced error scoring system, which we do in a physical therapy suite with a foam surface. I've actually have my own test. It's called the Sletten's one-leg pickup test, and it's a variation of that. And I messed up trying to film it myself, but basically have the athlete stand. It's about following directions, and that's a verbal sort of processing. I say stand on your left leg, and I throw the reflex hammer on the ground to the opposite side, and I say pick that up with your right hand. And they have to take that. It's sort of a Simon Says thing, and they have to do that correctly and stay balanced. And if you want to do the neurology on that motion, standing on one leg and picking something up from the floor on the opposite side, that's very complex. It requires right left brain activity and a lot of language processing. So that's my form of testing quick, and I do that almost every time they come in. I've taught other people to do that too. I'll find an enthusiastic grad student to do the study and write the paper. We do impact testing on all athletes when they come in. So we have a baseline that's right here. And then when they have injuries, we're able to compare this. And this is a computer-based system. We found that in the impact test, kids who are really good at computer games tend to do really well on some of the reaction time composites. People actually can get better at this as they do more of them. So that's not a perfect test, but it's a little bit of ammo for me sometimes. And what I mean is someone says, I feel good, I want to go back in, and I go, no, look at this. This test isn't quite back to baseline. Let's wait. And I think that helps me a little bit. Like I said, a little bit of ammo to keep somebody, help somebody to be a little more patient. I tell people some of the research on omega-3 fatty acids. And again, this is a neurochemical response, which is inflammatory on many levels too. And so there's some repair that needs to go on. And what we know about omega-3 fatty acids is, one, the EPA form of the omega-3 fatty acids are very anti-inflammatory in nature, as is some other foods in the diet. So I try to get people on an anti-inflammatory diet. The DHA component of the omega-3 fatty acid is the actual acid, is the actual fat that actually lives in our brain. 70 to 80% of the fat in our brain is actually the DHA form. So you may as well just give that to the brain that's trying to recover. And there's some good studies to show that that is helpful. maybe in response to concussion, and maybe and most definitely in prevention. So being on a diet that's rich in those substances is actually quite helpful. Okay, hyperbaric oxygen, and this has been really pushed for some of the old NFL guys, and the person heading this is actually I'm blanking on his name. It's the old quarterback for the Jets, and I'll get it in a second. See, I'm having a pneumonia, just like we've been talking about on the sideline. But in hyperbaric oxygen, what you'll see is this is also a blood flow test. And after hyperbarics, there's improved blood flow in the brain in general, and that's really good. And I think the earlier somebody can get in is the better. And the more someone waits, the less recoverability there is, obviously. And one thing about hyperbarics, it does a few things. It's potent anti-inflammatory, and it stimulates stem cells. And so in an injury, in an area of anywhere in our body that's trying to recover and regenerate, like was said before in a previous talk, there is regeneration potential. Hyperbarics stimulates that and encourages that. And I wish it weren't so darn expensive, but we've used it for a couple of our athletes who decided to do this after a number of concussions and weren't quite recovering, and they did very well. So I just say this, the magic word for me with an athlete is normal. And when I'm sitting there talking to them about their life and I go through sleep, thanks for the talk on sleep, because man, I do a lot of sleep hygiene, counseling with all college students. So, Aaron, that was terrific. And we talk about diet, we talk about appetite, we talk about relationships, and I just check off the boxes as I'm talking about it. And then I finally say, do you feel normal? And if they don't, then it's reason to pause. And I found that to be very useful with athletes, despite all the testing that we might be able to do that I've presented. So there's all that therapy that we've talked about with our group. And this is our 5-day return to play. Once someone is cleared by me, it's basically 1, 2, 3, 4, 5 days. It's for everybody. Every athlete gets it. And I don't care who you are, how important you might be to the team, it's still 5 days. Finally, there's some equipment changes in football. We have these concussion sensors and helmets. Doesn't necessarily prevent concussion. We have concussion spotters, and I'm proud to say that our head athletic trainer, Steve Greck, has been employed by the Rams to be a spotter, and he was at the Super Bowl. And then the full 90 headgear. And I know if kids are going to start using that, it has to be cool. They'll have to get some good designs if kids are going to start wearing those. In terms of rules changes, I heard from a neurosurgeon who said he would change 2 rules. One, change the special teams in football to change the whole kickoff. And they started to do that by pushing the kickoff a little forward. So you'll see a lot of these amazing kickers just kick it into the end zone, so there is no run back. And then another change in soccer might be the goal kick, which is a huge, that long kick by the goalkeeper. And then, 2 or 3 people are going to head the ball, and there's a lot of collisions that way. So thank you for listening. Thank you for supporting the CSUN Alumni Association, and wear your helmet. So I look forward to seeing you in person next time we do this. Are you ready for a little toss?
I am, Dr. Sletten. Thank
you.
I'll
try not to hurt myself this time. Ready? Here
yes.
goes. Oh, that's good.
Got it. Thank you. We're going to do so much information. We're going to go right next to our next speaker, and to introduce her is our undergraduate student, April Vega. April, you ready? Here you go.
Hi, my name is April Vega, and I'm currently an undergraduate in Radiologic Sciences. I'm currently the president for the Radiologic Sciences Student Association and the student representative for this Radiologic Sciences Alumni Chapter. I'm honored to introduce Lisa Naugle, a certified radiologic technologist since 1990 that has worked at Northridge Hospital Medical Center since 1991. She is certified in diagnostic X-ray, mammography, CT, and MRI, and currently performs imaging at a level 2 trauma center, pediatric center, and stroke center. She also serves as a clinical coordinator for the CSUN Radiologic Sciences program and is also a member of the CSUN Radiologic Sciences. Lisa, I'll hand it off to you.
Thanks, April. I appreciate the introduction. Nice to be with everyone today. I'm going to go ahead and share my screen and we'll get started. Okay. So just my disclaimer today is that I'm not a physician, so I don't prescribe or diagnose imaging studies. My role as a radiologic technologist is to perform the imaging studies. So working at a trauma center, pediatric trauma center, stroke center, we see a lot of patients come in for a lot of different reasons, a lot of sports injuries, a lot of playground injuries, motor vehicle accidents, falls, all types of things. So we see a lot of head injuries of all different types. So we're going to talk a little bit about imaging. I know some people had some questions and some imaging was covered already, but we'll talk a little bit more about concussion and imaging. So about 75% of head injuries can be categorized as mild traumatic brain injury or concussion. Obviously, as was mentioned and clarified before, this is a chemical change within the brain. It's not a structural injury to the brain. So diagnosis is made on physical exam and self-reported symptoms primarily, as well as some other tools that have been mentioned earlier today. Imaging methods such as CT and MRI do not demonstrate concussions. And I think that was touched on. So why am I talking about imaging? There is a role for imaging to play, so we'll discuss some of that. Some of the clinical recommendations for sports associations, CDC, the American Academy of Neurology, American Medical Society for Sports Medicine, really are refraining from routinely imaging, especially children, to diagnose concussions or mild traumatic brain injuries. The risks of the radiation exposure, as Dr. Sletten mentioned earlier, are significant. They're not inconsequential, and repeated injuries would mean repeated scans if we were using them on everyone. So there is an indication for a scan, why we would want to do a CAT scan versus MRI. Also, sometimes, depending on the age of the child, they might have to be sedated for certain types of scans. So they're really discouraging the use of routine imaging for everyone, and that's a good thing. That's a really good thing. So let's talk a little bit about computed tomography or CT scans. This is an example. You can see the picture here of a CT scan. It's really the first imaging step in ruling out more serious injuries. Since it doesn't demonstrate a concussion for us, what can it demonstrate and when would we need to use it? Things such as skull fractures, swelling or bleeding in the brain, some more critical injuries that would really require more perhaps hospitalization, surgery, ICU visits. It's the first step that we would use for that. It's fast. An average CT scan can take 5 minutes, literally 5 minutes. You put the patient on the table, we can scan their brain in about 5 minutes. So it's really easy to do. It's fast. Anyone can have one. It's widely available. Most imaging or most hospitals in the community have CAT scan imaging available for their patients. So it's really accessible for everyone. It can be expensive. If you don't have insurance, or if the actual insurance cost might be $1,200 to $3,000, so it can be an expensive method of imaging. But the one that's critical for our conversation today is it exposes the patient to a large amount of radiation. The average radiation dose for a CT brain without contrast is about 1.6 millisieverts. Millisieverts, that's not really going to mean much to most people, but it's the equivalent of about 7 months of background radiation given at a single 5-minute scan. For comparison, a chest x-ray is about 0.1 millisieverts. So we're talking about 16 times the amount of radiation that a patient would get getting a CAT scan of their head as they would getting a chest x-ray. So it's not an insignificant amount, something obviously we need to pay attention to and be cognizant of. So when is a CT appropriate? Here's a picture of a CT scanner, not at my hospital, but we do have the same type of scanner here. This involves, let me go back here. It involves a CAT scan, radiology imaging. So one of the reasons here, if I want to, hold on one sec, I want to go back to that scan. Sorry. So when would a CT be appropriate? Loss of consciousness. Anytime you have a loss of consciousness might indicate a more serious injury, so we would want to probably CAT scan that patient. Obviously, if the patient's having seizures, trouble speaking, they have one pupil that's larger than the other, blood or fluid coming from the ear or nose, that might indicate a skull fracture. Severe headache that's not going away, and severe vomiting also would all be signs of more serious traumatic brain injuries, and they would definitely be indications for a patient having a CAT scan. So here's some of those different types of serious traumatic brain injuries that we could see. Epidural hemorrhage, these are all CAT scan images. So you can see different types that are very serious, that cause pressure within the brain because the brain is encased in an enclosed space. If it starts to swell or it starts to bleed, there's nowhere for the brain to go other than to have increased pressure. So often these patients will have to go to surgery so they can remove part of the skull in order to account for the swelling or bleeding that's happening in the brain. They might put a drain into the brain in surgery, but these are life-threatening injuries. And these are the kinds of things we're ruling out when we're doing a CAT scan. They would require careful observation in the ICU. If a patient has a very tiny bleed, they would want to admit them, keep them in the ICU, monitor them for a long period of time, and then possibly do repeated CAT scans in order to determine, is that bleed getting worse? Do they need to go to surgery? Or is it remaining stable and we can just watch it over a few days and then finally discharge the patient home? So the other main imaging modality is magnetic resonance imaging. That's the imaging study of choice for patients that have symptoms that linger longer than would be expected. They have a late change in signs or symptoms. Patients having some of the symptoms that we've mentioned about concussion, suddenly those symptoms are really getting worse, or they're not going away past the expected time. You would expect a patient to have a recovery in 1 to 2 to possibly 3 weeks, although as we've seen from this talk today, that can vary quite a bit with each person. But basically their symptoms are not going away. So they're looking for some other type of significant injury that maybe was missed on the CAT scan, if they did have a CAT scan, or possibly they didn't. And because their symptoms are long-term, they want to investigate a little further and see what's going on in the brain. Now where a CAT scan would take 5 minutes, this could take 15 to 30 minutes. It's much longer process. Patient has to hold perfectly still. It's also widely available. Most hospitals will have an MRI machine available for them, or possibly in an imaging center that they're associated with, or a trailer outside. That's really pretty widely available nowadays. Very expensive. Again, I recently had an MRI of my brain and it was about $3,000. That was not my cost. That was the cost that they billed the insurance for. But it's an expensive exam, and no radiation is administered to the patient. It uses a strong magnetic field and radio frequency to create the images. Very complicated physical process, but there's no feeling for the patient, doesn't cause any pain. Many of you have had them probably, or you're familiar with them, seen them on television. So you know there's no radiation. It has a lot of noise, and it can demonstrate some smaller injuries such as small bleeds, scarring, bruising, structural abnormalities, pre-existing conditions that might affect their recovery. So here's an example of some MRI images. This would be an axial image on the left, a coronal image, which means it's like a front to back. We're facing the patient's looking back at us. So it can take multiple images all at the same time. There's a MRI machine down at the bottom. Some of the challenges for MRI is that it does require the patient to lie perfectly still. This can be a challenge for anyone, but particularly if patient's not feeling well, if they are compromised as far as their level of consciousness, sometimes they're not able to cooperate with us. They might require sedation. Very young kids, we image kids of any age because there's, for lots of different reasons, head injuries, playground injuries. Very young children might require sedation in order to help them lay still for 30 minutes. It's a long time to ask of a 5-year-old. So often we have to be prepared for that and work with the clinician in order to get sedation available and monitoring available so it's a safe process for the child. The magnetic field produces safety or image quality concerns. For instance, we have to screen patients very carefully, make sure that they don't have devices that would be contraindicated, such as pacemakers, aneurysm clips, different types of things that have been implanted in their body that might pose a danger to them when they do an MRI. Also, as far as image quality, any piece of metal or, for instance, something as simple as braces in a student's mouth can actually cause artifacts on the images. It's not harmful for the student to have an MRI. They can still have it, but we might lose some information that we want to because of the metallic artifact that, that braces would create. So there's been a lot of talk about this diffuse axonal injury. This is an MRI image on a 22-year-old male who had a very normal CAT scan after a head injury. They did monitor the patient because of the symptoms that the patient was exhibiting, so they sent the patient for an MRI. You can see on the right side of the image, all these little black dots are all these very, very tiny bleeds, diffuse axonal injury bleeds that did not show up on the CAT scan. So they went by the patient's clinical symptoms and signs in order to determine that they needed the MRI. So things that are invisible on a CT, if the patient's still getting worse or exhibiting strong symptoms, they might go ahead and order the MRI while they're in the hospital. So one of the things that was briefly mentioned earlier, I believe, was second impact syndrome. I'm referring back to my original slide because it shows diffuse swelling. This is a second injury to the head after a prior concussion that hasn't fully subsided or fully healed. It's rare, but it can often be a fatal condition of diffuse brain swelling. So this image down here would be an example of diffuse swelling. So there's swelling throughout the brain. You can't see the ventricles of the brain, which are these dark areas on the other scans, because they've been compressed with this overall swelling of the brain. Very serious condition. So chronic and traumatic encephalopathy was also mentioned, and this is a degenerative condition thought to be caused by repeated blows to the head. As we mentioned, it's associated with NFL players. There's a lot of, it can be associated with boxing as well, other conditions where they're getting repeated blows, repeated concussions. It's characterized by poor impulse control, mood disorders, suicidal thoughts, memory problems. Unfortunately, imaging does not really demonstrate this condition very well. It's primarily diagnosed post-mortem by determining the concentration of the tau protein, as Dr. Sletten mentioned, in the brain, and the degeneration of the brain tissue. You can have atrophy of the brain. We could see that on a CAT scan or an MRI. There's a lot of things that can cause atrophy, including age. So that alone is not an indicator that the patient has CTE. Really, they have to do more invasive and postmortem studies in order to determine that. So some of the other advanced imaging techniques that we've talked about, I know DTI was mentioned earlier. It can provide information about the integrity of the white matter tracts, which are the axons. They're the portion of the nerve cell that carries impulses away from the cell. The intact axons move water along their tracks. Damaged axons show water moving in different directions, so it's not a linear flow. And this might indicate small abnormalities in the white matter resulting from concussion, but can also demonstrate other white matter abnormalities. So it's not necessarily, I guess in the presence of concussion, it would be conclusive, but not necessarily conclusive because it can demonstrate other types of abnormalities. Diffusion tensor imaging, here's an example. So you see in the normal side, you see the nice nerve tracts that are all intact. On the head trauma side, you can see that there's areas that appear to be missing or damaged. And those are the neural or axonal tracts that are disrupted and the water is not flowing along them like you would normally see. One of the things about DTI, I mean, I work at a trauma center, pediatric trauma center. We're not doing DTI. It's not necessarily widely available. So not every hospital is going to have this technology, even though it's created with an MRI machine and MRI imaging. It's very specified. You have to have specific software in order to determine it, to be able to perform this test, as well as radiologists that are trained to read these types of exams. And some of the radiologists that I spoke to are kind of on the fence as to how effective they think this technology is, but it's obviously in process as far as research and investigation as to what we're using it for and how widespread we want it to use it. It is available in some of your major research medical centers like UCLA or Cedars locally. But not every hospital will have it, so it's not an option for everyone, and it's not necessarily indicated clinically as a routine for all concussion patients at this time. So some of the other advanced imaging techniques that we see, functional imaging was mentioned earlier. That examines some brain activity in certain areas while the patient's performing certain tasks. It's basically looking at the blood flow that's activated in different parts of the brain. Again, this is not available in every hospital or community hospital or imaging center all over the place. So some people might have it and it might be indicated, but this is also an area that's undergoing a lot of research in order to see exactly what the utility is for concussion management and concussion diagnosis. So we may see this occur more widely in the future as those studies continue on. MR spectroscopy measures changes in the normal metabolic activity in the tissues. As was mentioned at the very first talk, Dr. Conlan's talk, that concussion is a chemical injury to the brain. So there is thought that spectroscopy can demonstrate that. We do use spectroscopy for other types of brain problems, such as tumors or strokes, but there is no conclusive evidence that it's effective right now for managing concussion or diagnosing concussion, so it's not widely used. Some of the other imaging that was mentioned, PET and SPECT, these are still in research, and we may see these used more and more as the research progresses. The image resolution is inferior to CT and MRI, but not without merit, and this may be a more common imaging study in the future for concussion diagnosis or management. So diagnostic imaging does have a role in concussion diagnosis, but it's really secondary to prompt medical evaluation by trained medical personnel, as we've seen. More research will hopefully reveal improved ways to diagnose or evaluate concussion and assist in determining when it's appropriate to return to play. Some of my sources and my information, if you have any questions about imaging, I'd be happy to answer any of those. I hope this was helpful.
Thank you so much, Lisa. Lots and lots of great information.
I'm going to toss it back to you, Felicia.
Okay. I got it. Okay. So We are in the home stretch, everybody. If you need an actual stretch, please raise your hands, push your hands forward, whatever you need to do to get your little brain break and a movement break, because you are in for a treat. And we're going to wrap this up, and I'm going to hand it over to Rosemarie. Ready?
Ready. Got it. Well, everyone, for our last speaker of today, I am honored to present David Bobrosky. David Bobrosky is a shareholder at Lewitt, Hackman, Shapiro, Marshall, and Harlan, and part of the injury legal team at Lewitt Hackman. David is a CSUN graduate and has been practicing personal injury law for more than 23 years. David and his firm have represented several victims who have suffered both severe as well as mild traumatic brain injuries. David understands the challenges his clients face, as well as the challenge of proving the invisible injury in court. He is a founding member of the CSUN Attorney Networking Group. Are you ready?
I'm ready.
Here's the toss.
All right, thank you. I was going to joke like Dr. Sletten, have it hit me in the head, but I figured I'd mess up and it really hit me in the head, and I need the services of everybody here. So just skip that part. I know it's late. I know we're running behind. I know everybody probably is hungry for lunch. So I'm going to get right into this. Going to share my screen, and hopefully everybody can see that now. Give me 1 second. Okay. So here is my presentation on what you need to know about the invisible injury, the attorney's perspective. But why an attorney? Why am I here? It's because everybody loves attorneys, right? Yeah, I know that's not true. I know nobody likes an attorney until they need one, but it's okay. I'm used to that. So again, why am I here? I'm here because concussions are not just suffered during sporting events, and they're not just suffered by athletes. Concussions, or what they're known as mild traumatic brain injuries, are suffered by everybody. It can be suffered by any one of us, and it can be suffered in any normal everyday activity, whether it's a car accident, whether it's somebody trips and falls, whether something hits somebody on the head. It can happen at any time. And I represent a significant number of people who have suffered these mild traumatic brain injuries, and I know the difficulty in proving really what is truly the invisible injury. Now, not all traumatic brain injuries are created equally. This is a picture of a former client who, as you can see here, he had a motorcycle accident, and part of his skull was removed to allow the swelling to go down, which is, I believe, Lisa just mentioned she has seen before. And that's how bad his injury was. They had to take away the skull, swelling on his brain went down. Now, this is a picture of him a few weeks after the accident. If I tell you now 3 years later, he's still suffering with significant symptoms from his brain injury, you're probably going to believe me after seeing this picture. And if I show you this video, I'm going to show you a video of an accident. It's not too gory, but it does show what happens. You can see this lady, hopefully you can see her crossing the street in the crosswalk. The car is going to turn left here. And unfortunately, if you can see there, it ran her over. And these were the pictures of her shortly after the accident. And you can see the big gash in her head here. Now, again, if I tell you 2 years later, she's suffering from significant symptoms from this, you're probably going to understand that. It's not going to be that difficult for me to prove that. But what if I show you a picture of this gentleman? And this picture is taken just a few weeks after an accident where he suffered a whiplash injury and a concussion, or a mild traumatic brain injury. And then I tell you 2 years later, he's suffering from significant symptoms from that concussion. Are you going to believe me? It's going to be a little more difficult for me to prove, right? Because this is truly the invisible injury with something like this. Now, concussions, which we keep talking about interchangeably here today with mild traumatic brain injuries, are classified as a mild traumatic brain injury. And many times you see the designation of a lowercase m and a capital TBI, MTBI. That's a mild traumatic brain injury. And there are generally 3 classifications of traumatic brain injuries. There's mild, there's moderate, and there's severe. Here are the elements of each one. Moderate and severe, I'm not going to really go into. You kind of know it when you see it, like those pictures. Those are easier to prove. Mild traumatic brain injury. Here are the three basic elements. Either you do not lose consciousness at all. So again, you do not have to lose consciousness to have a mild traumatic brain injury, or your loss of consciousness is less than 30 minutes. But think about that. You could lose consciousness, be knocked cold for 29 minutes, and is classified as a mild traumatic brain injury. Doesn't sound mild to me. There's memory loss lasting less than 24 hours, and there's a GCS score of 13 to 15. Now, a GCS is a Glasgow Coma Scale, which I'm going to talk about in a couple minutes. Okay, again, mild. Even though when we call it a mild traumatic brain injury, I think it gets more attention than a concussion, mild is still misleading. Mild traumatic brain injury can be a major injury. A mild traumatic brain injury can leave the injured person with major functional limitations. And the effects of a mild traumatic brain injury can be long-term. So mild is not how we use it in everyday language. Here, mild is simply a medical classification of a very severe injury. I think we have to remember that. It's just a medical classification. It doesn't truly mean mild. But again, it's my job to prove that when I'm representing someone who has suffered that. But you don't have to take my word for it, because who takes an attorney's word for it anyways? We can go to the CDC. And here, CDC talks about medical providers may describe a concussion as mild because they're usually not life-threatening. Even so, the effects of a concussion can be serious. CDC is telling you that. Now, there's some recent research finally starting to catch up, and that was mentioned before, that research is usually 10 years ahead of just public awareness. And the research, even in this, for the longest time was that most people recover within a few months of a concussion or mild traumatic brain injury. And that's certainly what the public was thinking. So if you're coming in saying you had problems after that, really wasn't that. Maybe it was psychological. If it's in a personal injury lawsuit, maybe there's secondary gain. But now finally, the research has been coming out. This is from 2017. And in this, it says, in contrast to the prevailing view that most symptoms of concussion are resolved within 3 months post-injury, approximately half of the individuals with a single MTBI, concussion, demonstrate long-term cognitive impairment. Okay, this study says half of the individuals with a single MTBI demonstrate long-term cognitive impairment. That's huge. That's a huge change in what the research was. Here's another article. Talks about most patients with MTBI presenting to US level trauma centers report persistent injury-related life difficulties at 1 year post-injury. Okay, most patients have persistent injury-related life difficulties 1 year later. And that was whether it's with work, socially, whatever it was, whatever life difficulties they had it more than a year post-injury. Again, that's very different than what the research was showing not that long ago. So if the CDC saying if the research is catching up, why is it so difficult to prove? One reason is, again, the public awareness is still behind and still catching up. But again, it's truly that invisible injury sometimes. Sometimes there is no direct blow or obvious injury to the head, and you don't need that. It can happen from the acceleration, deceleration. We've talked about it a little bit today already. The next slide is going to play you a quick video from the CDC that shows it and explains it, and hopefully you can see it and hear it.
A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
Now, again, you don't need the blow to the head. The brain, just the head moving back and forth quickly can cause the brain to move around inside the skull. And I have a model here of a brain inside the skull. What I wanted to show you is inside the skull is not smooth, especially down below. Hopefully you can see that, but there's a lot of bony ridges inside the skull there. So the brain bouncing around and hitting those bony ridges can cause significant injuries and so it has bleeding in different places. And this next slide talks about a coup contre coup head injury. This is when there is a blow to the head, and coup contre coup is French for blow, counter blow. So when there's a coup injury, if there's a blow to the head, it denotes that the injury to the brain is on the same side where the blow to the head is. But what happens is once there's a blow, the brain is going to bounce back. And the second picture shows the brain hitting the back of the head now, and it's being injured on the back side also. So you have injuries on the front and the back of the brain, even though the blow is to the front of the head. And, you know, Bob Saget obviously had that, you know, horrific and, you know, horrible accident causing his death recently. And regardless of, you know, they talk about that it was a fall that caused the injury and the fractures were all over the place and bleeding was on different sides of the brain. It can happen when there's a significant blow on one side, that brain is going to get bounced around and bleeding is going to be on various sides of the brain. Okay, no direct blow, and then no loss of consciousness. Now, again, we don't need loss of consciousness to prove an MTBI, to be classified as an MTBI, but it certainly helps in the minds of people who are judging us, for example, when we're in court. But many times we don't have it, or we don't have it because it's not accurate. Right? Because let's say it happens after a car accident, you can immediately get in the car accident. You could be knocked out for just a second or two or 3 or 4 seconds, and you may not realize it. Usually the person who lost consciousness is the worst person to tell you if they lost consciousness or not, because they don't know. If somebody's with them, they'll be able to say, hey, yeah, you were out. I was trying to call your name. You didn't wake up. But you may not realize it. And the police or paramedics arrive there. They ask you, hey, are you okay? Were you knocked out? Say, I don't know, you know, I'm dizzy, my bell was wrong, like we've heard today, but I think I'm okay. No loss of consciousness gets in the records, and that tracks through the whole case. Glasgow Coma Scale. So the Glasgow Coma Scale is a tool that was developed in the 70s, used to describe the level of consciousness following a traumatic brain injury. And it's used a lot in the field by paramedics, it's used in the ERs, and it has its place and it's important. But in our field, it's improperly used or relied upon because of a couple reasons. One, it's a subjective test, and two, it really can change over time. And there's 3 main parts to it. There's eye-opening response, there's verbal response, and motor response. I'm going to focus on really eye-opening and verbal response right now. And if there's three parts, if you get a perfect score in each one, you add up to 15, and that's a normal Glasgow Coma Scale. Anywhere 13 to 15 is classified as a mild traumatic brain injury. But again, it's pretty subjective. Look at eye-opening response. Eyes opening spontaneously. If they do that, you get a perfect score of 4. So think about it. You could be lying on the curb after a car accident or something hits you, and your eyes could be closed. And if the paramedics walk up with all their gear and their boots and they're loud and they put their box down and your eyes open, you're going to get a perfect score, 4, right there, depending on who's, you know, doing the grading and how they do it. Verbal response, orientated. Again, you could be sitting there looking at pigs flying through the air, completely confused. But if somebody asks you what your name is and you answer it, you may get a perfect score. Now, somebody may score it differently. We don't know. It really depends who's scoring it in the field. And sometimes it's different in the emergency room. But also, even more importantly, it changes over time. What if you were knocked out for 5 or 6 minutes and you didn't know what your name was or where you were when you came out of it, but paramedics don't get there, or any type of assistance doesn't get there for another 10 minutes. And by that time, you're able to answer questions, you're coherent. It's going to show a Glasgow Coma Scale of normal, okay, a perfect score. And again, people are going to look at those records and say, all right, you didn't lose consciousness, there's no blow to the head, and you had a normal Glasgow Coma Scale. So really, how badly are you hurt? No positive imaging. There's been a lot of talk about imaging today, so I won't talk about it too often. But again, concussions, mild traumatic brain injuries don't show up on CT scans. CT scans are used in the emergency room less now than they were before, which is what you've heard. But again, they're really looking for bleeding within and surrounding the brain, fractures to the skull, and they're almost always normal with the concussions. It just doesn't show them. I'm going to just kind of, again, quickly go through these. MRIs typically don't show them. There is more advanced sequencing on the MRIs, which you've heard. DTI, SWI sequencing will show it sometimes. It will show the axonal shearing. And if you can show it in those pretty pictures you saw, then that is very effective for us to correlate it. But again, it doesn't always show it there. And we kind of assume going in, we're not going to have that imaging. Functional MRI, again, looks at brain function as opposed to the structure, and that can show some problems. But all of this advanced imaging, while it's great and it is advancing, the court system is a little behind too, because as Lisa mentioned, not all the radiologists, neuroradiologists are on board on exactly what this shows and the meaning of it. So they don't even always come into evidence. It's usually a battle of our medical experts if it does show something, whether or not it's going to come into evidence. Few more here, which we already covered before. All right. Concussions or mild traumatic brain injuries are usually missed or misdiagnosed in an emergency room. Now, why? It's not because emergency room doctors aren't great doctors. They are. There are heroes. But it's what Dr. Sletten mentioned earlier before. They have a primary role in the emergency room, and that is to determine if you have a life-threatening injury, and if you do, what care you need to save your life. They're not necessarily concerned whether or not you're going to have some concentration issues 8 months down the road. So they have a job to do. But when that happens, sometimes these things get missed in the diagnosis. And these studies are now showing this. This study showed that 56% of the mild traumatic brain injury cases identified by study personnel did not have a documented mild TBI-related diagnosis in the emergency room. Okay, so more than half, when they confirmed it was a mild traumatic brain injury later, when they went back and looked at the records, more than half of them did not have that diagnosis in the emergency room. Here's another one. And this, again, talks about how serious this problem is. Mild traumatic brain injuries are a serious public health problem. Is referred to as the silent epidemic, and although the least severe of all, the most challenging to identify. And in this one, again, of all the confirmed mild traumatic brain injury cases, when they went back and looked in the records, only 23.1% of them had that clear diagnosis in the record. So almost 80% in this study were missed. So again, that makes it very difficult for us. You don't have the blow to the head. You may not have a loss of consciousness. You may have a normal Glasgow coma scale. And now you have and you may not have positive imaging. And now you have the trusted ER doctor, again, who's doing his job, but it may not be diagnosed in the emergency room. And the number one reason why they're difficult to prove is that the injured person usually looks and sounds like this guy again, completely normal, okay? But we know the patients and our clients are still having these significant problems, despite all these other things that say they shouldn't. So how do we prove them then? We have to use a combination of medical experts and lay witnesses. And we heard a little bit about this before with the medical team. You know, we use a neurologist who, if they have the positive imaging, that's great, they can correlate it. But if they don't, they do it through what's called a clinical diagnosis. They take a history of the injury, they look at the patient's symptoms, and they diagnose the person with a mild traumatic brain injury or a concussion. But again, neurologists, you have to find one that works more in the brain injury field. All of them touch on it. There's some that understand it more than others. In our cases, they're usually the quarterback for us, and they refer out to other medical specialists. Speech language pathologists, we have several great ones here today, and they're very important. They do additional testing, and they provide crucial treatment. They are the one specialist actually with everybody we deal with that gets our clients back on the road to recovery. So they are absolutely vital. Neuropsychologists are usually more testing and assessment. You assess people with difficulties with memory, concentration, planning, other cognitive issues. And that's when you hear neuropsych testing. This can be helpful. It can show deficits in certain areas. But without a baseline, it can also be difficult. Because if you had a high-functioning individual who before the concussion or the brain injury would have been scoring off the charts, and then after they're just scoring average, it may not look so bad as average if you didn't know what their scores were before. Psychiatrists and psychologists are very important. This, major depression is in 25% of patients with TBI cases. But I kind of find it's even more than that in our practice. People get very depressed with these symptoms. And it's not even depressed because of their symptoms. There are actual changes in the brain that cause the depression. So it's a very serious issue, and it's a very important component of our cases. A life care planner, usually a nurse or a rehabilitation specialist. They evaluate individuals with their disabilities and see what care they need in the future and how much that's going to cost, so we can get that provided for them. And it comes in, it's most important when there's impaired judgment. And so they need attendant care, because think about it. If someone could be looking like they're functioning normally and every day, but what if they get that call from someone in Nigeria who says, just send me $5,000 and you're getting a brand new Tesla in your driveway tomorrow? They don't realize they're not supposed to do that. Or what if you have the woman who doesn't realize Amazon's not delivering her package at 1 a.m.? Her safety is at risk. So if it's that serious and it's that kind of impaired judgment, we have to make sure there's attendant care provided for these people. We use non-expert witnesses also to show the before and after. We want people who knew them before and have seen the changes in them after. So it's usually family, friends, coworkers. And usually anybody is better than the person themselves, because brain injured people are terrible witnesses for themselves. One, they've obviously suffered a brain injury. And two, they may not realize what issues they're truly having, or they may not want to come to grips with those issues. And when we have people testify in court, many times we have to have the client leave the courtroom because it could be damaging to them to actually hear how bad they are. And we handle a lot of significant injury cases, a lot of significant physical injury cases. People have, obviously people have been killed, people have lost loved ones, people have lost limbs. And those are very difficult cases. But many times the brain injury is even more difficult to deal with the physical injury, because there's nothing worse than losing your ability to think, to reason, to remember, and to not be depressed. That you simply can't get out of those problems. And I'll leave you with just this, and everyone can get on with their day. But this is a couple more pictures of a client who you could see on the left. Prior to his accident, he was a fun-loving, athletic young man, and afterwards, he really stayed in his room and couldn't go out and do much else. And when he did, he had to wear noise-canceling headphones. He had to have sunglasses on. This is a picture of him at his deposition. It's hard to tell, but the lighting is really dim there. So if you get anything out of today, and I think you have gotten a lot, especially from all the other professionals that have gone ahead of me, but my hope is that you have a better understanding for what people are dealing with who have suffered a mild traumatic brain injury, and whether you come across them at work, your friends, your family, or even one day sitting on a jury in judgment of what somebody's dealing with. Hopefully now you'll have more compassion than you did before today for someone who is suffering from a mild traumatic brain injury. And that's it for me. So thank you very much, everybody. I really appreciate it. And I was honored to be part of this panel.
Thank you so much, David. You really wrapped up all the things that we have talked about today. I realize it's running a little bit long. I wanted to thank everybody. If I can just have all our speakers and all our volunteers come forward, and these are the people behind the scenes and in front of the scenes that have helped put this talk together for all of you. We'd like you to look at the link on the chat. We'd love to hear from you to find out what you've learned from today and what you would like going forward, because this opportunity for collaboration and bringing to this the community is something that is very important, especially for this topic. And if any of you want to connect with all of us, we have I'm going to ask Jenny to put up our contact information. That is also in all the slides. And so you can reach out to any of us. Here is our contact information. You can take a quick screenshot of that. And I would also like to thank every single person here for their time and their energy and their enthusiasm. There is so much more that we could actually tell you about concussions. We tried to synthesize it as much as we could and bring it into just enough information so that you could talk to your loved ones, your coworkers, your peers, or anyone and have a talk about the discussion about concussions. And then in the next slide, I just want to show you, let me see if you can forward the next slide, our thank yous to all the alumni chapters who helped co-host this event, our colleagues from Cal State LA and Sac State, and all your students who came to support, also the CSUN students. Thank you so much. The Communication Disorders and Sciences Alumni Chapter, the Education Alumni Chapter, that's always hard for me to say, Radiologic Sciences Alumni Chapter. Wow, go forward, whoever's doing that. There you go. And the Attorney Networking Group and the Public Health Alumni Chapter. And again, thank you to everyone for being here today. If you look in the chat, we have opportunity also for questions and answers. I know many of the things were already asked in the Q&A section. So if the speakers would be okay for like the next 5 minutes, if there are any questions, if someone has any questions, put it in the chat. Otherwise, it is survey time. If you could fill that out, we'd love to hear from you. If you'd like to join our Alumni Association and find out more, membership is free to our alums, and you'll get to hear and interact with people like David and Lisa and Aaron and all the people here. So thank you so much for being with us. Let's see, are there any questions? Do you guys see any questions right now on the Q&A?
Several students or several attendees are asking about certificate of participation. I don't know if you or Jenny want to comment on that quickly.
Yes, so if you fill out that survey, we'll get a chance to get your information, get your feedback, and then we'll send it to you digitally. Okay, anybody else have any questions? Don't forget to donate to the CSUN Alumni Scholarship Fund, it says there. We certainly would love to have that opportunity. If you would feel like you would like to donate, your impact would be doubled. And we thank the CSUN Foundation and the Alumni Association for providing that opportunity to give our students a helping hand through our scholarships. So thank you for that. Okay. There's some more chat information. Does anybody else have any questions? Oh, there's a Q&A. Okay. I heard about helmets. Athletes hit differently, especially in football. I watch rugby. Recommendations. Does anybody want to take that? Dr. Sletten?
Yeah, thanks. And I think that question came up on the side. I don't know if it's the same person, but that was my response. Is like, is the helmet considered a sort of a false sense of security? And obviously some rules changes have come about to try and decrease the helmet-to-helmet contact. And I think it's been a really good thing. You know, if we're going to continue playing these sports with all this data coming out, there has to be rules changes to decrease these high velocity impacts. And also the low-grade sort of repetitive injuries that athletes have, which may not be anything at all. And that's still new data. And so my response was like, have you ever watched a rugby game? Because the techniques in that sport, these guys are giant and they're running into each other at lower velocity. And they've learned from the time they were 5, 6 years old how to protect their head and use their shoulders and their torsos to do what they want to do in that sport. So you know, we love football. And I'll say, to use a quote from the movie Friday Night Lights, I think it was like, if you're from Texas and you don't play football, you ain't nothing. And I think that goes to that participation and the social value of being part of a team and balancing the risk for head injury is really significant here. So I think, I don't think football is going away, nor should it. I'm glad for the rules changes. I would love to see maybe even change the whole kickoff special teams thing, because it's just a free for all in that particular sport with helmet or no helmet. So the quality of the helmets have improved And I don't think it's making a difference necessarily in the concussion incidence in this case. And I think that was also answered as like, does a helmet prevent concussion? The answer is no.
Right. Okay, the other question, thank you, Dr. Sletten, is there literature on people with autism who are sensory seeking and hit their heads with their hands or on a surface? This population is huge for SLPs. I'm thinking they might give themselves a concussion, which may further exacerbate these behaviors. Who would like to take that?
I sort of took that. I tried to type. I'm not a fast typist for that person, so I'll try to say what I was trying to type on the side there. That's what I was doing when you called on me last time. But actually, in my practice in Ventura, I see kids on the spectrum. That's kind of why I do this practice. It's called Sletten Wellness, but it's mostly for little kids on the spectrum, and we deal a lot with self-injurious behaviors to the head. And I have one of my patients who's unfortunately institutionalized. And he just has a big giant knot on the front of his head because he just keeps hitting the front of his head, and it's so sad. And it's an impossible population to study, really. So the people who are at that level of that condition, of that disease, are usually so difficult to manage that to get them studied is a problem. So the presumption is that they're having some chronic brain trauma, but it's very hard to measure, and that's the hard part. So we do all these things. There's all these novel ways to treat self-injurious behavior to try and decrease the frequency of that, but it's really heartbreaking. It really is.
And in the education setting, it's also important because we have students who may have falls or, have some type of head injury. Sometimes they aren't able to communicate, or they have a device and don't know how to get that information out. So that is a whole other area, I think, that as educators and as speech language pathologists and anyone that's involved in traumatic brain injury is to consider that component too with kids with autism or those who have communication deficits. It might be difficult for them to communicate exactly what they're feeling, or something's off. How do they communicate that?
Yeah, the speech therapists have become communication specialists, not necessarily speech therapists. They've become experts not in like helping kids how to say S's and W's and L's, but actually how to get what's inside out. And that's where the creativity comes in for this population.
I don't know if any of my other colleagues would like to speak on any of the other questions that came out on the Q&A that they were able to respond to individually. Is there anything else that you would like to share with the audience? Some last minute thoughts. Nancy? Dr. Cohick?
Thank you. Just one thing, Kristen was asking about bringing the Team Up Against Concussion program to her area. So if anybody is interested in this, please contact me. I'm in the LA area, but I can certainly work with you. And whether you're a speech pathologist, we can get together. So anybody interested, please email me at ncohick@calstatela.edu, and we can figure out how to coordinate training.
I'd like to also thank all the people that are on the East Coast, and we had Texas, Oregon, Missouri, just different states, and also from the United Kingdom, people that have come to our conference today. So we have an international conference, guys. So you don't know where your words have reached. Hopefully it'll be exponentially passed on to all the people that have attended here today. Okay, anybody else? Okay, I'm looking at the chat. Anything else? No. Okay, so thank you again to our audience, to our speakers, to the alums, and to anybody that has come today. Thank you for the opportunity to share our knowledge and experiences. And hopefully this won't be the last time we'll get together, because there's so much more information that's coming out. Thank you again for all your time. And I'm going to ask our group to hang out a little bit just for a second, and we will thank Jenny and all her alum supporters for all their help. Yes, yeah. I don't know how to do the emoji. So I like that, Lisa, that works. Nonverbal communication works too. Okay, thank you all.